I was thinking about that. I was like, is it actually?
No, actually, never.
So yeah, I like the actually like, you know, I was thinking that. I can see that.
You're still a baby. They're probably proud of me. But yeah.
Oh my God.
Either way better.
The one on the most off
the
looks
front
better.
Yes.
Yes. No, the second, that one.
Yes, that's good.
How are you gonna see?
We can't see them.
You can't see
You
them.
can't see that at all.
Our eyes will strain.
Oh, I should have not been strained trying to see what you're doing either. Okay, I promise I took a shower, so you guys can feel free to sit up here. But today we're going to talk about GI, in particular, problems that have to do with the esophagus, the stomach, small intestine. So this lecture in particular has a lot of new terminology. And I would make sure that, you know, when you're looking through the PowerPoint, the book, those kind of things, really hone in on terminology, because if you don't know what the word means, you can't remember to fit it into the question. You can't really answer the question correctly. So that's one thing about GI. Another thing is thinking about what part of the GI system the problem occurs in. So we know the functions of the parts of the GI system. You know, if we're talking about the esophagus, we're talking about a tube-like structure that has lots of tissue, that also has some muscle, peristalsis, that goes on. And there could be inflammation and lots of bleeding that can occur there with irritation. But we know also that when the esophagus goes into the stomach, we want that valve to be able to close. So if there is extra pressure in the stomach or things like that, that valve can open, and that contents like stomach acid can go back up into the esophagus. And that can erode the esophagus, causing bleeding, causing inflammation. And if we have inflammation in the esophagus, then it can prevent things that we swallow from going down correctly. And lots of bleeding can occur, lots of very tiny blood vessels in the esophagus. So we said that the stomach has stomach acid, and we need stomach acid. So we need a good balance. We don't want too much, but we don't want too little either. If we have too little stomach acid, and we'll talk about some medications we use to kind of decrease stomach acid, and why those should really be short term, because stomach acid is important for not only food, and so we can absorb the nutrients from it, important things we need like proteins and calciums, but also for killing bad bacteria. And so some of the things that we ingest may have some bad bacteria, and if we didn't have that stomach acid, it could be absorbed and we could get really, really sick from that. So we don't want the stomach to go into the small intestine though. So we have another valve there, and when those contents go into the small intestine, they should be neutralized. So bicarbonate in the small intestine to neutralize that stomach acid, because the tissue that's in the stomach is very different than the tissue that's in the esophagus or the small intestine. And that stomach can erode the small intestine. We know the small intestine is used for absorbing nutrients, right? So if we have problems with the small intestine, then we don't absorb the things that we need. And then going from the small intestine to the large intestine should be used to pull in water that we need to help with peristalsis, movement, but it's not in particular used for absorption. So if we move things very quickly through the system, through the small intestine, and it gets to the large intestine, we're not going to absorb those nutrients. The large intestine we'll look at is very muscular in itself. And the purpose is truly to have that peristalsis and continue to move things and compact things that are waste products to move out of our body. And any of those areas can have inflammation, and inflammation can partially or even completely block passage, okay? Any of those areas can have tissue damage that leads to bleeding. And bleeding in particular can be problematic for our patient, depending on how much bleeding. Think about the other things going on with our patients. Are they on a blood thinner? Are they already maybe not getting enough nutrients, so not absorbing enough nutrients? All those kind of things. So when we think about disorders, what part of the system is affecting? And that can help us to see why they could be very problematic for patients and even symptoms that those patients may have, okay? All right. So here we got kind of an overview, not only of the direct line of the GI system, but accessory organs. And so we need to think about those accessory organs, but in particular, for the next lecture, after our exam, we're going to talk in detail about some of those accessory organs. And so those things definitely being the liver, the gallbladder, the pancreas, and knowing that those have very important functions as well that affect the GI system. So if we take medications and we swallow them, they go through the enteral route. So through the GI system, we swallow them, they're broken down in the stomach, absorbed in the small intestine. That also has to go to the liver to be able to metabolize and kind of break apart those waste products from the things that we need in our body. So if the liver's not functioning properly, then we may be able to really break down and use the things we need. The liver's also important for blood clotting. So if we have liver problems as well, and we have irritation in the GI system, we could have lots of bleeding from that, and patients can become anemic, have additional problems from that. Okay. Gallbladder is used to store bile, and so bile is an important component that's used to break down things like carbohydrates and fats, and it's a storage unit. So we can live without the gallbladder, but it's used for storing that bile and sending it directly when we eat, and so kind of having that squeezing mechanism. Yes?
How do the gallstones happen? Bile's not there, right?
Gallstones can happen at any time,
Okay.
Truly.
Okay.
And
How does it not go to the stomach?
I'm sorry?
How does the gallstone not go to the stomach?
Well, it gets caught in the very tiny tubes,
Oh, okay.
and we'll talk more about it.
Not right now.
Well, I would talk about it now, but I don't want to add more to your plate right now. And then the pancreas, we know, has functions of endocrine. So it excretes insulin, okay, and also makes glucagon for glucose balance in our body. But it has exocrine function as well. It makes digestive enzymes like amylase and lipase and tryptophan, those kind of things that when they're excreted and go into the small intestine, they help to break down food. So additionally, very important functioning organs to be able to use the GI system effectively. So they all go together, okay? So how does the GI system change as we age, okay? And important for our patients in knowing that they may be predisposed to certain types of health conditions due to problems that occur with age in the GI system. As we get older, we decrease the amount of stomach acid that we make, and we said that it serves an important purpose. So decreased levels of hydrochloric acid, the stomach acid, can lead to decreased absorption of things that we need, particularly vitamins, minerals, and even some proteins. And we also said that the stomach acid was important for killing bad bacteria. And that could be things that we ingest, food, water that may have some contaminants in it. And so if we can't get rid of that, we can't kill that bacteria, we could get really, really sick. So older patients are more at risk of becoming ill from things that they eat that could possibly have some contaminants. We have decreased sensation to defecate. And so that's the peristalsis, in particular, that's the end of the large intestine, or what we refer to as the colon. And that peristalsis in that area helps to have a sensation not only of moving things along the way, but of being able to compact things, pull in water. As we get older, we said that we have decreasing amounts of hormones onto water, so we pee more frequently. And that water that we're losing is really important for pulling it into the large intestine to be able to compact the things and move them along. So it also affects the GI system. It can lead to things like constipation, impactions, impaction being stool really kind of blocking the area that's very difficult to pass. And we said lots of medications that we take as well can decrease our fluid. Foods that we eat may not have a lot of fiber and things like that. So we'll talk about that and really encourage fluids, making sure that we do get adequate amounts of fluids, exercise, this is peristalsis, and being able as well to take in fibered foods. And so that could be a fiber supplement, that could be fruits and vegetables. And as we get older, many times we don't eat the quantities of things that we do either, and that helps peristalsis. We have decreased lipase levels. That's a pancreatic enzyme. Okay, so it results in decreased fat absorption. And that passing through our system, increasing amounts of fat can cause problems with bulking up of stool. So we have lots of kind of gas and air in the intestines as well. And that decreases peristalsis. It kind of puts pressure on the intestines so they can't move as well. And then decreased enzyme activity. So again, things that are excreted that break down the things that we take in. We don't metabolize drugs as well because we don't break them down as well. That can lead to problems with building up of dosages of medication in our system. So our metabolism, the way that we break things down is slower. So we may have an incidence or an increased incidence of drug toxicity. Our body not breaking down, metabolizing drugs and getting them out of our system in an adequate time before we take another dose of medications. So one of the things that's recommended as well is if there is a recommended dosage of a medication, they're probably for someone that's older going to start at that lower end of the dosage because it may take a while for that medication to leave their system, and we don't want them to take another dose and have very high levels in their system. So problems with moving things through and breaking down. Right. What can we do? What kind of things can we encourage our patients to do to help with those things? So we said encouraging adequate fluids, but also if we're not eating as much food, as quantity of food, and I haven't reached that point yet, I'm still eating well above my quantity, I'm sure, but encouraging things that are nutrient dense. So things that have lots of vitamins and minerals, and avoiding things that really don't have a lot of nutrients in it. A lot of things that don't have a lot of nutrients, the kind of things like fats and sugars, they fill us up. And so we don't eat as much of the other things. Encourage, we said high fiber. One thing about fiber is we have to get enough fluid with it and get some exercise, because if not, fiber can constipate you. So it kind of has that extreme of both ends. So when we encourage patients to have a high fiber diet or add fiber, it can make you very constipated and gassy. And patients will say, it made me sick to my stomach, I'm not going to do it anymore. So we encourage them to increase slowly. So taking in foods that have fiber, so things like apples and green vegetables and all those kinds of things, as well as adding, changing to whole wheat or high fiber foods. So breads, pastas, those kind of things that can be whole wheat instead of white, that can increase fiber. And then also maybe if they need more fiber, increasing maybe a fiber supplement, but you have to get plenty of water with that. And then also be able to get up and move around, or they're going to run into some problems with constipation. Fiber, 15 mLs of fluid intake daily. Again, so at least 1,500, but we also have those patients that are on a fluid restriction. So thinking that they may be predisposed to constipation as well. Small eating, so instead of patients as they get older, having these 3 big, huge meals when they're not that hungry and because they're not getting enough exercise. You know, we don't need as much. Maybe having some smaller meals and snacks throughout the day that are healthy. Assess for things like diarrhea that could be due to medication, excess urination medication. So assessing for dehydration as well, because that can lead to constipation. And assessing for adverse effects of drugs. We said they were high at risk of that because of slowing down of that metabolism in our body that breaks down things. All right. Lots of GI questions, and so I'll let you guys read through those. But it asks about kind of the things we take in, signs and symptoms of things that could indicate a problem. So stomach ache or gassiness or diarrhea or constipation. Also problems along the way. Do you have problems chewing? Do you have problems swallowing? Do you have acid reflux or heartburn? Do you have lots of episodes of gas or bloating? Any of those things could have to do with diet. And then also looking at other causes as well. We want to know about their rumination pattern, asking about traveling outside the U.S. Why would we want to know if they've traveled outside the country? Yeah, so it could be things eaten that aren't free of bacteria or parasites or things like that. They could have a gastroenteritis, an inflammation of the stomach due to some of that bacteria. We said they don't break down the bacteria as well as someone who's younger because of that low stomach acid. And then asking about things like, is there a change in your usual pattern? Does the stool look different? So different diseases can make stool look very different, have a different color. And then also we want to know about things like bleeding as well. And have they ever had an endoscopy or colonoscopy? Endoscopy goes down the throat into the stomach and the small intestine. Colonoscopy goes in the rectum, at the large intestine. So as if they're having problems, then they may recommend an endoscopy. We can look at the esophagus and the stomach and the beginning of the small intestine, and then recommending a colonoscopy, and we'll talk about that in more detail. But the American Cancer Society recommends that beginning at age 45, that people have a colonoscopy or a stool test for blood at least every 10 years. Now, if you have one and then they find something like a polyp and remove it, they may recommend more frequent screenings. But talking to patients about have they started that and helping them get that set up. Okay. So what kind of tests can we do to see, do they have good GI health? Are there any problems that are going on? We can look at a CBC, right? So we can assess to see if there is any bleeding. Looking at their red blood cells, hemoglobin, hematocrit, we can look to see if there is any bacteria or infection. Looking at a white blood cell count, we can look at their clotting, right? We can look at platelets, we can look at PT-INR, which is not a CBC, but we can look at their clotting factor. Okay? We can look at their electrolytes. So looking at things that they could be taking in, are they absorbing enough of those things? Particularly things like sodium and potassium and calcium. We can look at enzymes, and we'll talk more about those in our next lecture, but things like AST and ALT. We said the liver is very important for metabolizing things that we take in, breaking down those medications. So how's their liver functioning? Amylase and lipase, those are pancreatic enzymes. Again, we said that was important because they make digestive enzymes. Go into the small intestine and break down those foods that we need. Are they making enough of those? Okay. Bilirubin is a component that is in bile. Bile is important as well. One of those things that again helps to break down things like fats. And so if our patients don't have enough bilirubin, they can't make bile, store that bile in the gallbladder, it's made in the liver. We can't break down things that we need. Okay. Ammonia is a byproduct. It's a byproduct of breaking down protein. Okay? And again, it's a big function of the liver to be able to break those things down and get to the body. We'll talk about again in this lecture and more coming up that if we have high levels of ammonia, that's a byproduct, a waste product, then we can make us very, very ill. And it's because the liver is very slow in breaking those things down. The liver is not working well. So our levels of that waste are building up and building up because the liver can't break it down and get it out of our body. Okay? So are the organs functioning the way they should? And then we can look at some different kinds of labs that test for cancer. So things like stomach cancer or esophageal cancer or colon cancer. Now, we don't just routinely, if someone comes into the hospital, the doctor's office, screen them for all of these things. Many times, like we said, one test, if it's abnormal, can lead us to another test. So in particular, the CA19 and CEA and there's PSA and all different kinds of tests that test for high levels of things that are with certain types of cancers. So if they suspect a certain type of cancer, in addition to kind of going in and looking, they may do a blood test to say, is there any waste product or product that is excreted by these tumor cells that say, yeah, there probably is a high likelihood of that. So getting more pieces to the puzzle of what's going on. Also, we want to do screening exams. So we don't want to wait till someone is sick or has cancer or things like that. We found that if we can screen for people that are at high risk being age, could be sex, could be lifestyle, signs and symptoms. If we screen for those things and find them early, they have a better likelihood of survival and less kind of disability and problems that result from that. So when we said in particular, when we're talking about the GI system, colon cancer is something that is important to diagnose. One of the things, if we can think of something, I guess if we can think of something that may be kind of positive, is that colon cancer is what's called an adenocarcinoma, which means that it grows on the inner lining. So we see it very early in its growth. So if they go to do a colonoscopy, they can see very small growth and remove them before they become very invasive. So colonoscopy is kind of the gold standard, really, because we're not doing something like a blood test or looking at stool that could possibly indicate. We can go right in there and visualize the colon and say, is there something in there that could even be considered precancerous, like a polyp, just an overgrowth of tissue that can be removed that doesn't have the signs truly of being cancerous yet. We're not going to wait for it to become cancer. So with a colonoscopy, we said that screening should start at age 45. And with that screening, they say you can either do a stool exam, so they even have Cologuard and some of those things that are in commercials now where they truly send you a little kit and you catch your stool and you take a sample of it and you send it to them. They can test for blood. That is for people who are at average risk, have a family history of colon cancer. They haven't had a abnormal finding on a colonoscopy, those kind of things. So they say that people may be more likely to do that because it's less invasive. So if they're not going to get a colonoscopy, this is better than nothing, truly. So it can indicate if there are any abnormal cells, and then they would recommend a colonoscopy. But patients also can get a colonoscopy at age 45, and they say 45 in particular because that's when our risk increases. And that's also when insurance says they'll pay for it, right? So if someone's younger than 45 and they have a family history or they have signs and symptoms like bleeding or things like that, they would definitely recommend them getting that early. But colonoscopy every 10 years. If they're just doing the stool, they recommend it every year. And so we have to tell patients what they need to do to prepare for it. And truly, when they go in to do a colonoscopy, it has to be clean in there so they can see the walls of the intestine. So they're going to have them to do a bowel cleanse. And that truly is giving them something to make them have lots and lots of diarrhea so that it will completely clean them out. In addition to not taking anything by mouth other than maybe some clear liquids. We want to let our patients know that when you take this medication, it's going to make you have a whole lot of diarrhea. You know, if we didn't, then they start having diarrhea. The patient may say, well, I stopped taking it. It gave me diarrhea. So we want to make sure they know what to expect, right? It's probably good that you block off that period of time to not go places and you just stay home and do the prep. The prep many times can be started one evening, so let's say 5 o'clock. If they're going to have colonoscopy the next day, it's that effective. And it can be either pills or a liquid that they drink. And many times they'll have to drink repeated doses of it to, like, maybe they say have 3 doses or 4 doses. And it truly will definitely work on them. So that bowel happens, they're going to have them not have anything to eat or drink for about 6 hours before the exam. So when they start the bowel prep, they say they can have some clear liquids. So you can have some popsicles, or you can have some Sprite or things like that. But truly after, you know, about midnight, that 6 hour level, don't have anything to eat or drink. We want to make sure that everything is moved through. It requires sedation. So patients are going to be given medication in an IV, like Valium or Versed, sedatives, hypnotic, that make them very, very sleepy. They'll be able to wake up very quickly from that. They won't remember anything, but they don't have to be intubated, but they do need a ride home. So patients have to have someone come them. If they have something done during surgery, they may, while they're doing the colonoscopy, they may remove polyps or just overgrowth of tissue. They may remove large hemorrhoids if those could be blocking the pathway. So they can do some kind of procedures while they're in there. And they also take some very lovely photos that you get to take home. So we want to monitor things when patients are recovering. We said they're very, very sleepy. We want to monitor their respiratory status, right? They're waking up from sedation. We want to make sure the gag reflex has returned, and it should return very quickly. But we want to make sure that we make sure they can swallow properly, they're not having any drooling, and that when they are awakened and are able to do that, they can have some small drinks of liquid, and then after they wake up, they're able to go home or go back to the floor or wherever they're at, and they can resume their diet. Safety is important. Again, side rail, making sure that they, if they get up, that they're steady on their feet, that there's someone with them. If the biopsy was performed, they could have, or if hemorrhoids were removed or anything kind of done, they could have a small amount of bleeding, so make them aware of that. They may have some fullness and they kind of blow some gas in there to spread the areas of the intestine apart so they can see things very clearly. So they may have some kind of feelings of fullness or gassiness when they go home. And we want to tell them what to look for. So we want you to watch for any things like excessive bleeding, dizziness, feeling lightheaded. Those kind of things could indicate that they may be bleeding. And there is a risk with any type of really procedure, but a risk of this invasive procedure of perforating the bowel. Now, it's very rare, but if they do, the contents of the intestines will leak out into the peritoneum, and we get peritonitis. And peritonitis is kind of going to be our word of the day. Everything really leads to peritonitis. When things leak out into the peritoneum, it's very vascular. There's lots of blood vessels. It can seep into the blood system and give us sepsis, and patients can die from that. So making sure that if there are any indicators, abdominal pain, bleeding, fever, any of those things, that they know that's very important. And then we're losing fluid, so changes in vital signs, tachycardia, hypotension. Okay. And I got a video there that kind of, or I'm sorry, I got a link there that kind of talks about the latest recommended guidelines for a colonoscopy. All right. Okay, so let's move to the esophagus. And we said one of the problems that happen is gastroesophageal reflux disease. Patients don't think it's particularly serious. We have lots of over-the-counter medications, but it can be very serious and even predispose patients to cancer. So it's extremely important that patients, if they use over-the-counter medications, they use them as, but if it doesn't help, they also need to see a physician. Okay. So looking at the esophagus, we said that the pH of the tissue in that area is very different than the stomach. The pH of the stomach is about 1.5, very acidic, and of the esophagus and the small intestine, it's about 6 to 7, more alkaline, right? So that pH in the stomach, that stomach acid, if it goes into those other areas, it can be very, very damaging to those tissues. Yes.
In our NG tube, it said that the stomach is around 5 pH.
I'll have to check on that.
Okay.
Okay. It may be the stomach.
Okay.
I'll check on that, yeah. So in assessing the esophagus, it leads into the stomach. And in that area where it goes into the stomach is called the lower esophageal sphincter, meaning that it opens and closes. Should open, correct, when we're swallowing things, they go down in there, but then it should stay closed because we want those contents of the stomach to backflow into the esophagus. So some things that could cause it to backflow could be a change in position. So patients that are more at risk of that opening, when we're lying down or when we're bending over, when we're bearing down or coughing, those kind of things can increase the pressure in the abdomen and cause that valve to open. So that'll kind of coincide with some of the things we talk about avoiding if you are having acid reflux, and we'll look at that. But patients are going to complain of pain, usually pain in the esophagus, which is interpreted kind of as heartburn. It could also be a sore or kind of a raw throat. The taste of that acidic kind of taste of stomach acid. Patients also could complain of problems breathing. So one of the things that can happen is, particularly when patients are sleeping at night, if they have that esophageal reflux, it can go down into the trachea and into the lungs, and patients can have asthmatic type symptoms. So that's one of the things that when patients are having particular problems with asthma or breathing, and they talk about when is it worse? Well, it's worse in the morning. They may look at maybe it has to do with stomach acid, and so maybe trying them on some medications for gastroesophageal reflux and see if that helps those problems with breathing in the morning, irritating the trachea and irritating the bronchus. Risk for aspiration. So again, irritation that could go into the throat, that could cause patients to have problems with swallowing. And so some of those liquids or foods can even go down into the trachea and into the lungs. So can cause a risk for aspiration. Risk for alteration in nutrition. If I'm having lots of heartburn when I eat, sore throat, those kind of things, I probably don't want to eat. And the things that I'm going to eat may not be very nutrient dense things. So it can change my nutritional status. So lots of problems that have to do with that. And again, that lower esophageal sphincter, we said, is important to be closed. If it has a lot of irritation and inflammation from that acid, it's more likely not to open and close correctly. So patients can even complain sometimes, it feels like food is getting stuck. It's not going down right. So if we suspect that a patient could be having gastroesophageal reflux, we will recommend some lifestyle changes, but they also may do some diagnostic testing. One of those things is the EGD, or the esophageal gastroduodenectomy. And so they're looking at the esophagus, the stomach, and the small intestine. Known as an upper GI endoscopy, a kind of endoscopy. And so they may go in and look at the esophagus and say, is there any erosion in that? Is there inflammation near that lower esophageal sphincter? Is there any bleeding in that area? They can also do something called a 24-hour ambulatory esophageal monitoring, in which they actually have patients that kind of swallow like a little pill that has a camera in it. It's really bizarre, but it kind of, it takes a picture kind of all the way down and all the way through their body, and you kind of leaves the body and you flush it and those kind of things, but it records as it goes down. So what's going on at all parts of the system? They may start medications, and we'll talk about these in some detail, but it could be things like antacids that neutralize some stomach acid, could be H2 blockers or histamine 2 receptor blockers, things like Zmac, Pepcid, could be things like proton pump inhibitors, so things like omeprazole and pantoprazole. And also they may use something called a prokinetic agent. Kinetic means movement, so increasing the movement of food through the system. And so we know that if things sit in the stomach for a long time, it increases pressure, increases the risk of gastroesophageal reflux. So are they having problems with moving things through the systems? Are they really constipated and things sit there a long time? They can also do a surgery to decrease the risk of gastroesophageal reflux. So let's say they've done all these things, they've tried all these things, but maybe that lower esophageal sphincter is so damaged that it's not going to close correctly. They're going to continue to have those problems. We want to do something to prevent them from happening because we said it could damage the esophagus, erode the tissue. We know that if tissue is damaged, when it repairs, the more times it is damaged and repaired and changes, the can change, they can become mutated, and the risk of cancer increases. So we don't want that to happen. They can do something called a Nissen-Flynn duplication, and it's a pretty common surgery. And what they do truly is they take kind of the top of the stomach and they wrap it around and they secure it up itself. And truly what that does is it narrows the opening, but it also gives less room for a direct pathway for things to leave the stomach. So before we had them just leaving, and now it may have to go this way and come around this way and go up that way. So it's a little bit harder due to gravity to get things back up. It's also going to be harder to get things down. So patients are instructed to make sure they chew their food very well, not to use straws, and that sounds kind of weird, but that builds up the gas and things in their stomach that can damage that suture line. If there's very large pills, they may have to break those up, things like that. So let's look at some types of medications. Like we said, lots of over-the-counter medications. So patients don't really know the difference in these, right? They say heartburn, they say antacid, prevent stomach acid, prevent heartburn. So how are they different and who should be taking what? First, we'll talk about the antacid. It's kind of the least, what we think of as invasive. It's least likely to really change what the body's doing. So the body still needs to produce stomach acid, but an antacid, when we take it, you do a couple of things. One thing is it's kind of milky. It coats the lining of the esophagus, so that stomach acid is less likely to damage that after meals. So if we take it before a meal, or we take it as the first sign of heartburn or gastric reflux, but then it also kind of neutralizes some of the stomach acid in the stomach. So if it does come up, it's not as acidic, it's not as damaging. We don't want to take it continuously for a long time. We said we need stomach acid. So many times what will happen is if patients are having a lot of problems, that doesn't mean that they just started having gastric reflux. What it means is it's getting pretty damaged in there. So if they take it for a week, 2 weeks, it can let the esophagus heal, and then they can do other kind of lifestyle things to decrease that risk and going forward from there. An H2 blocker is kind of a step up from that. So a histamine 2 or H2 blocker, what it does is it decreases the amount of stomach acid that some of the pumps are putting out. So things like famotidine or ranitidine or cimetidine, so things like Pepcid and Zantac, those kind of things, again, take preferably for a shorter period of time. Now patients do take them daily, so preferably if we can decrease, again, the amount of acid that's being made, let the esophagus heal, and do some other lifestyle changes that can decrease our risk of GERD, that's the best plan. A step beyond proton pump inhibitors. So what they do is they go directly to the pump and they shut down some of the pumps in the stomach that make pepsin, which is the stomach acid. They shut them down completely, so only part of our pumps are working. So we see how it gets a little bit more invasive every time. When we're taking pump inhibitors, we're making less stomach acid, less likely to break down foods the way that we should, less likely to be able to kill bacteria, less likely to break down nutrients like calcium. Patients that take proton pump inhibitors daily for a long period of time are at increased risk of things like osteoporosis. They're not breaking down those nutrients so we can absorb them the way they should. So there are some really kind of contraindications for long-term use. And that's why it's so hard, because they're over the counter and people think they're safe. They're over the counter. If they weren't completely safe, they'd be a prescription, right? So talking to patients about, again, what are they taking? What over-the-counter medicines are they taking? When we say what medicines, people don't think about telling us about things like that. That's over the counter. So when we think about heartburn, we said this is particularly talking about the proton pump inhibitors, suppressing the production of acid totally, okay? We can get infection from that bacteria building up, that bad bacteria building up. Proton pump inhibitors also can cause some of that good bacteria not to be able to proliferate as well. So we want some of that growth of good bacteria. It's fighting with the bad bacteria right now. The bad bacteria can overtake it. And we need good bacteria, again, to help with gut health, to help with immune health, absorbing some of those things that we need. Possible side effect of fractures, okay? Side effect of osteoporosis with long-term use. Iron and B12 deficiencies, again, not absorbing the things that we need in the quantities that we need. Okay. And then I've got over here kind of what kind of symptoms we're having or patterns we're having with heartburn, and what's a suitable medication for that. So if we have intermittent short-term heartburn, but we need fast relief, I'm getting it after I eat, I'm having symptoms, try an antacid, okay? It neutralizes, it should coat the esophagus. Longer lasting episodes, particularly at night. That lower esophageal sphincter relaxes, pressure in the stomach. Try an H2 receptor agonist. Try something like Zantac or Pepcid. If it's predictable heartburn after certain foods, and we know we're going to eat it, we could go ahead and take an H2 receptor agonist. They don't work immediately, but we're going to go out and we're going to be eating lots of things that irritate it. We can go ahead and take it to help make it start to work then. If patients are having frequent episodes and need frequent treatment for more than a few days, proton pump inhibitors are great, but they really shouldn't be used for long-term use. Okay, so increasing kind of symptoms, frequency, or increasing levels of medication. Yes.
So is antacid the first line?
Yes.
And if that doesn't work to be prescribed, then you go to the next, and then if that doesn't work, the PPI is the last one to be prescribed?
Yes.
Okay.
Yes, it should be. And so we said they're over the counter, so patients many times, they're going to go right for the proton pump inhibitors, right?
Them would be like just taken as needed, like they're not going to be scheduled.
That's a great question. So antacids many times are taken as needed. Okay, so think of like taking Tums or drinking Mylanta or something like that. They're really as needed. With that coating and milk, it can also cause some constipation if we drink too much of that. H2 receptors, they can kind of work both ways. So we can take them if we're planning to eat something we shouldn't, going out, eating a big meal, things like that, or they can be taken daily. Sometimes they can be recommended twice a day. And then proton pump inhibitors are things that are taken daily or as a schedule. They take a little bit longer to work. So here's again a picture of that Nissen-Flynn duplication. We've got this big neck here of the stomach, and so we have a pretty clear pathway of things being able to go up there, but they take this larger kind of neck and they wrap it around and so it's kind of like a toilet bowl, I guess, of having to kind of go around before they can go kind of back up there. So it makes it a little more difficult pathway for things to move up and down. Another thing we can kind of assess the esophagus is, well, in the stomach too, is something called a barium swallow. And it's a frequent exam again. And patients may have an amount of barium to drink. It's really thick and milky and chalky. And it comes in a kind of a big bottle, and they will come to the floor and say, it needs to have a barium swallow. They need to drink this within 20 minutes. Well, that's kind of difficult for us to do for some patients. We can help and try. but they can't do the test unless patients do that. So we kind of coax and help in those kind of things. It's better if it's cold. We don't want to mix it with anything. We said it's big and thick and milky. It doesn't taste terrible, I don't think. It doesn't smell bad. Patients don't really complain about it, but it's the texture, I think. Drinking it, it kind of adheres to the esophagus and the stomach, and they can, when they take pictures, those areas kind of light up. So they can really look at not particular things like polyps or bleeding, but they can look at the structure of it. So is there any enlargement that could be due to inflammation? Is there, again, blockages? Is there a problem with the pathway? Those kind of things that would light up, and they do an x-ray. Yes?
Will they take like one picture after they swallow, or is it like a series throughout like the day?
Oh, that's a good question. No, after they drink the whole thing, they come down to radiology, and then they just take pictures there.
Okay.
Yeah. Now, they can do something called a barium enema as well. So if patients are going to have something like the large intestine looked at, they're not going to go in there and look at it. They're going to take x-rays to see if there's any enlargements or strictures like closures that would prevent things from moving through. They can do barium in an enema that really truly looks at the large intestine. It's important that after patients have a barium swallow that we really encourage lots of fluids to kind of help wash it out because it's chalky and milky and can really cause constipation. Okay. All right. So other views with gastroesophageal reflux, that lower esophageal sphincter at the top should be closed. And so if we have backflow of that, again, due to the change in tissue and pH, it can damage those tissues in the area. And patients, again, usually complain of that sour stomach, heartburn. Okay. What kind of lifestyle things can they do? Well, we're going to recommend eating 4 to 6 small meals a day instead of 3 huge meals a day. If patients particularly are having heartburn at night, not eating within about 2 hours of bedtime at least. And then don't eat your biggest meal at the end of the day because it takes a long time to process those things. Avoid eating that can increase stomach acid. So things like fatty foods, caffeine, alcohol, tobacco, chocolate, all those kind of things could increase stomach acid. Avoid snacking in the evening, eating in the evening. Chew the food slowly and completely. The longer, the more kind of it's not chewed, it's going to sit in the longer to break it down longer, making more stomach acid. Remain in an upright position for at least 2 hours after eating. So that's why we say don't eat within, a meal within 2 hours before bedtime, because if we lay down and we have all that digestion and increased stomach acid and pressure, it's going to open that lower esophageal sphincter and we're going to have that acid reflux. Straining. So again, think of things that put pressure on your stomach. So things like bending over right after we eat, or things like constipation and straining, so avoiding constipation. Patients also may be at risk when they're pregnant, so lots of pressure in the abdominal cavity. Patients that have obese or overweight, increased pressure in the abdominal cavity. So maintaining proper body weight, avoid sleeping flat. It may help if they sleep elevated on a couple of pillows. So what does it look like if there's damage to the esophagus? When we go in with that endoscopy, that EGD, go in, they can look at erosions. So I kind of think of those as like canker sores on the inside of your mouth, if you bite your cheek or anything like that. That's what they look like. So areas of erosion that are trying to heal. And then also we can see in this lower esophageal sphincter how it has some of those ulcers and redness and edema. How is it so problematic? Okay. So if we have gastroesophageal reflux disease and we have repeated injury and damage to the tissues of the esophagus, we can develop something called a Barrett's esophagus. And so it says there's specialized intestinal metaplasia of the esophagus. What happens is that the esophagus, the tissues in that area, start to build scar tissue. It starts to build tissue that is made to accommodate that pH, right? So the tissues in the esophagus that they take a sample of don't look like the tissues that should be there. They look more like the tissue in the stomach. And the more it changes from the tissues around it, mutations that happen, the more likely it is to mutate into cancer. So the increased risk of cancer. That Barrett's esophagus, again, if they take samples and it's very, very different from the tissues around it, it's considered to have what's called a high-grade dysplasia. Dysplasia means different kind of cells. So how different are cells from the cells around it? If it is very different, it's mutated and mutated and mutated from chronic damage, that is truly leading to cancer, because that is what cancer is. It's cells that have continued to mutate and mutate until they've damaged the DNA and mutated into something that no longer is like the cells it should. Doesn't grow like the cells it should. It can overgrowth. We have these kind of polyps in enlarged areas. It doesn't stay where it should. It can break off and go to other areas. It doesn't do the job that it should in the esophagus, so it doesn't kind of squeeze and move food through. And that truly can lead to that adenocarcinoma, that cancer in the esophagus. So we want to prevent repeated episodes of this gastroesophageal reflux that can lead to that adenocarcinoma. They don't talk about that on commercials, do they? So let's talk about something else that affects the stomach. This is called a hernia, or particularly a hiatal hernia. Okay? So we said that the esophagus leads into the stomach. Well, there's also something that helps with keeping the esophageal sphincter closed, and that's our diaphragm. So we have the diaphragm, those muscles that help with our respiratory effort of expanding our lungs and breathing, but it also joins together at our esophageal sphincter. So in that area as well, it kind of helps to hold the esophagus where it should and the stomach where it should. But if we have increasing pressure in the stomach or around the stomach in that area, it can push the stomach in areas it should not be in. So we have the diaphragm and the esophagus and the stomach. If we have increasing pressure in this area, the diaphragm gets weak, and we said that happens when patients have chronic respiratory problems as well. Both of these things happen. What can happen is with that increased stomach pressure, some stomach can be pushed up above the diaphragm. And that's truly called a hiatal hernia, a herniated portion of the stomach. Okay. Sometimes if you are assessing your patients, you will have them lie down and look at their stomach, and they'll have a big lump. And I usually poke it and say, "What is it?" Because they know. And it's not painful. It shouldn't be painful. If it's painful, that means that they could be having lack of blood flow to that area, and we'll talk about that. But many times what will happen is it will go back on its own, but it also has a high risk of coming back up on its own. Some physicians will try to reduce it or push it back to where it belongs. It continues to come back up, then they can do something like suturing it down there or something like that. But many times if it's not problematic for the patient and it continues to move, they just don't do anything about it. They just tell them what kind of signs to look for that could be serious. Or different types of hernias. This one's called a sliding hiatal hernia, which means that the diaphragm just doesn't stay where it belongs enough, so the stomach continues to kind of slide back up and down. Increased risk of GERD. There's nothing helping to hold that closed. It just slides up and down. And this is called a rolling hernia. So due to the pressure down here, it kind of pushes a portion of that stomach up there, and that makes that big lump. So when is it problematic, or what makes it problematic? If it is pushed up into that area where there's less space and the diaphragm pinches it up there, it could cut off the blood flow to that part of the stomach. So a strangulated hernia is where the blood supply is cut off. It's an emergency. Patients can have lots and lots of pain. They can become very nauseous, have vomiting, and lack of blood flow means death to the tissue, right? So we don't want that to happen. An incarcerated hernia is where the hernia is trapped outside of that peritoneal cavity, up into that thoracic cavity. And if it gets trapped, it can lead to this strangulation. So the fact that it's up there and does not move back down kind of means it's incarcerated at higher risk of that lack of blood flow. We said it may be reducible. Reducible is where the hernia moves back into the peritoneal cavity. It may do it on its own. Or the physician may be able to use their fingers and push it back down there. But we know if it's come back up once, it's very, very likely it's going to come back again. So again, what kind of is the patient having? Is it painful? Is it sometimes present and sometimes not present? So these are the things that we really have to watch for to ensure that it's not dangerous for that patient. We can kind of see here where the diaphragm it is, and part of that stomach is kind of pushed up in there. So this is where that little sphincter is, and it's kind of slid up here where part of the stomach's up here. More likely to have that esophageal reflux, so that's what they kind of look for as well in those EGDs. But then also, it could be pinched off in such a way that this area really shouldn't be, and it could cut off blood flow. All right, so let's move down to the stomach. We said that there could be inflammation in the stomach, and that's called gastritis. Anything with itis after is inflammation. We can have esophagitis, inflammation of the esophagus. Gastritis, anything gastric is stomach, so inflammation of the stomach. So what kind of things cause inflammation? We said one is increased stomach acid, but we said in the stomach acid should be there. So what else could cause it? Right? So we can have ulcers or little ulcerations or sores in areas where there is damage, and we kind of describe what kind of ulcer it is by where it's at. So we can have a duodenal ulcer, the small intestine. Some of that stomach acid has leaked down into the small intestine and damaged it, the duodenal ulcer. We can have a gastric ulcer in the stomach. We can have an esophageal ulcer because the stomach acid is leaked up here. When we think about an ulcer, about a sore, and we also think about its very thin skin and vascular and risk of bleeding. If that ulcer continues not to be able to heal, so we continue damaging, the ulcer gets deeper and bigger and can actually eat through the lining and into the peritoneum. So what does that result in? Peritonitis, okay? So that's the kind of end result of what's the worst thing that can happen, and that's peritonitis. But in the interim, we can have lots of pain and irritation, inflammation that doesn't let things pass. We could have bleeding. So watching for those kind of things. Patients, again, may complain of heartburn, stomach pain, diarrhea. Could be some malnutrition, right? We're not absorbing things. Could be bleeding, so maybe I'm vomiting with some blood in it. Okay? We have a lot of bleeding and we pass that into the stool. We either might be able to see it or might not, but when they do our stool test for our colon, it may detect a small amount of blood in there. So how do we prevent this inflammation in the lining of the stomach? Doing things to prevent excess stomach acid from building up. We said there are things that make us make a lot of stomach acid, and things that could make food sit there for a very long time, making that stomach acid. Eating a well-balanced diet. Again, if we're eating lots of things like fatty foods and things that are hard to break down, it's going to sit there a long time in the stomach. We make much more stomach acid. Avoid drinking excessive amounts of alcohol. Alcohol can affect the liver. It can also affect the lining of the stomach. And again, the liver makes clotting factor. If we have irritation and we start bleeding, we can bleed a lot. You use caution in taking high doses of medications that can increase bleeding. Things like aspirin, things like NSAIDs that could damage the lining of the stomach and cause bleeding. Lots of patients, particularly patients that have chronic pain, may come into us with a GI bleed because they have taken NSAIDs and they've helped, but now they don't help as much, so I may take more, and I may take them more frequently than I should, and I may take them for longer than I should. So increase of breaking down the lining of the stomach and having GI bleeding. Avoid excessive coffee, even caffeinated coffee. Both of those can increase stomach acid. Be sure that the food and water we eat are safe. So again, if our stomach detects something that is a bad bacteria, it's going to make more stomach acid. So be careful about the things that we eat, where they come from, especially if we're traveling. Stop smoking, blood vessels. Protect yourself against exposure to toxic substances in the workplace. Things like lead and nickel, those kind of things can damage tissues as well. So we can breathe those things in. They can be on things in the atmosphere. We can touch them. They can absorb into our system. They can damage tissues throughout the body. And then seek medical treatment if they're experiencing GERD, particularly if it's not being helped by medication, or maybe it was helped and then it came back, or things like that. So it's really not something to kind of ignore. We want patients to seek help for that. So again, some things that can cause it: eating too much, eating too early, eating too late in the day, eating things that could be contaminated, and then taking in things like alcohol or NSAIDs or aspirin that can increase stomach acid and can damage the lining of the stomach. Acute gastritis is come on rather quickly, okay? We'll look again in a minute at things that are more chronic, but these kind of things within a couple of weeks, they can really cause a lot of damage. Taking too much NSAIDs, eating something contaminated, within about 48 hours, we're going to start having symptoms: vomiting, diarrhea, stomach pain, could be some bleeding, abdominal discomfort, nausea, vomiting, anorexia. We don't want to eat. It's making me sick. Makes my stomach hurt. Could be headache. Okay, again, we become dehydrated many times. Could even cause hiccuping. Again, eating too much, eating too large a quantity, taking in lots of air, eating those kind of things. How do we manage it? Patient usually recovers within a few days, but we said if our patient is having vomiting and diarrhea, they can become very dehydrated. So again, making sure that patients are staying hydrated. Many times if patients have kind of a food poisoning or stomach and they're having vomiting and diarrhea, we want to keep them hydrated, but we don't want to completely stop that, because it's the body's way of getting rid of those things that are toxic to the body. So keeping them hydrated, maybe decreasing some of the symptoms, but we don't want to give them so much that totally stops all the diarrhea, because that's truly doing that. And if there's bleeding present, we need to see a doctor, and it could lead to maybe even having surgery if that patient's losing a lot of blood. If that patient, what we're doing for it doesn't help it. And we said in the stomach in particularly, we don't want to stop the stomach acid completely. So if bleeding does start in those areas, it's very hard. What causes more of a chronic gastritis, meaning that it gets worse over time and it is pretty much continuous? Could be an autoimmune problem, right? And so we'll talk about some of those, particularly with the large intestine, but we could also have an autoimmune disorder where our body kind of attacks in our body, and that can cause damage and irritation and bleeding. May need to take a medication that is kind of an immunosuppressant. Could be bacteria. One of the bacteria that is very instrumental in causing gastritis, stomach ulcers, those kind of things, is called Helicobacter pylori. It's very common. People have it and they don't even know. But it can damage the lining of your stomach. It also causes increased stomach acid to be made. So some of the things that they may do if somebody has GERD and they continue to have problems with it, or kind of an upset stomach or painful stomach, is test for this bacteria. And we'll talk about kind of how you get it, but also you can get rid of it. Things like smoking and alcohol and NSAIDs, all those things, getting rid of those things that could be contributing factors. So not doing them anymore. What do we want to do to see if that's the problem? We can do that upper GI, that endoscopy we said. They can take some biopsies of some of those tissues, particularly if there's damage to tissues. They're going to samples of those cells and the cells around it. How different does it look? Is it kind of similar but a little bit different, so it's just a kind of a new thing that started? Or is it very, very different and enlarged? That means that we're really in some risk of problems. We can also do blood testing. They can test the blood for this A. pylori and antigen and those antibodies we build up. Other tests for H. pylori, they can do what's called a breath test. You can breathe into something and it could indicate if we have some of those byproducts. They can take a saliva sample. So there's lots of different ways they can test for that bacteria. And then the signs and symptoms are very similar to the acute gastritis, heartburn, particularly after eating, we're making more stomach acid, anorexia, nausea, vomiting, sour taste in the stomach, in the esophagus, in the back of the throat, belching, burping a lot, lots of gas and air, and then some vitamin deficiencies. So vitamin B12 and iron and calcium from malabsorption of those things. So we want to ask patients if they're having any paresthesia. What's paresthesia? We talked about paresthesia when we talked about doing a neurovascular assessment.
Like the numbness.
Yeah, numbness and tingling. Why would we want to know if they were having numbness and tingling? Close. It actually has to do with a deficiency of vitamin B12. So one of the things that if we're not getting enough medication like B vitamins that are helping the neurological system, we can have numbness and tingling, and it can damage that nerve transmission. So some of those weird sensations, like my hands are getting a little numb and tingly, and that could be due to lack of absorption of nutrients. So sometimes we ask patients questions and say, I know this is going to sound like a strange question, but it has to do with that. With chronic gastritis, here's kind of an acronym of ABC. So is it an autoimmune problem? Is it a bacterial problem like Helicobacter? Or is it chemical, meaning things like medications, alcohol, that could be affecting it, and smoking? So like if there's chronic problems, we can kind of see and hear some of that like petechiae that's in the stomach, small intestine, and that's from irritation and some small bleeding that's underneath the tissues. So we don't want them to eat anything that's irritating. Again, talking about foods that can irritate the stomach, smoking, alcohol, NSAIDs. We're going to treat the bacteria. Is it a bacteria? So if we test and we think it's bacterial, we have a positive H. pylori, they're going to treat them with antibiotics. Okay? They're also going to replace any nutrients that they're lacking. So we might be replacing B12. Some B12 injections, checking their iron, having them take iron or giving them an iron infusion, those kind of things. We want to encourage stress reduction. Why would we want to encourage stress reduction? Yeah, that increased stomach acid with stress, anything that speeds up the metabolic system, stomach acid. Also things like exercise. Sometimes patients will complain they get gastroesophageal reflux or stomach aches after they exercise. That could be particularly if they already kind of are at risk for those things, and we build up a lot of that stomach acid. Promoting optimal nutrition. We may be keeping the patient in. Maybe they have so much damage that they want it to heal. When symptoms subside, then we may offer them some clear liquid. So it may be even if they go in and they do some cauterization of those areas, kind of building that diet back up. We want them to stay hydrated, make sure they get electrolytes, so they could have some IV fluids if they're inpatient. We relieve their pain, but not with things like NSAIDs or aspirin. So relieving pain in other ways, particularly things that may coat the esophagus and the stomach. Avoid irritating foods, discourage smoking and alcohol, again, to allow that to heal. So treating that, but also decreasing those things that increase the levels of that stomach acid, or killing the bacteria, or getting rid of anything contaminated they may have taken in. Okay. So we said it's very common. Half the world's population is colonized or infected. Colonized meaning we have that bacteria, but it doesn't cause us a lot of problems. But many do not develop the disease. Okay. You can pass it to other people through saliva, eating, drinking, kissing, all those kind of things. It's a bacteria. It is What it does is it decreases duodenal bicarbonate secretion. So it prevents that neutralization of acid leaving the stomach to the small intestine. We can have problems with that sphincter, that pyloric sphincter that goes from the stomach to the small intestine becoming irritated and inflamed, and also that duodenum there becoming irritated and inflamed. It contains proteases that degrade the mucosa. This bacteria makes these proteases, and those are digestive enzymes. And so they break down the stomach lining. We can develop peptic ulcers, also known as gastric ulcers. We can get ulcers in the stomach. If we continue to have those problems and those tissues continue to change immune, those are called metaplastic changes or changes to the tissues. It can produce chronic gastritis, and that can increase the risk of stomach cancer. So diagnosis and treatment are very important. Again, some of the ways we can diagnose it: blood, a breath test. They can look in the fecal sample. They can use an endoscopy and take a sample of cells. All those things that they're going to do to say, is that a possible cause of what's going on? Yes.
What is a breath test?
So a breath test is when it makes these proteases, they can detect it in our breath. So you breathe into this like little bag container, and it has a strip that changes color if it detects that in your breath. Yeah. All right, let's go ahead and take a break. I kind of got ahead of myself there.
I don't want the syrup. I don't like it at all. Like I tried a little bit and I like the almond one. I hated it. I didn't even finish it and the syrup was in it. Almonds.
I got it with extra soy milk because like the soy milk has vanilla in it, and that actually made it a lot better.
Well, I did not like that.
I have to get extra condiment though. I have to get extra syrup. I don't know. It's like you have to like make. I don't know. It's hit or miss.
I know, it really is. That's like every new Starbucks shop, I'm like, oh my gosh, let me try it. And then I'm like, what?
That's why I don't try a lot of new things.
That's why you just gotta do the same thing
Yeah.
over and over. No changes once you find something.
Yeah.
Keep it simple.
Yeah, because if I don't like it, even if I think, well, maybe it'll be different next time, I won't do it again.
I know, and then someone said, oh, Autumn, you'll love the pumpkin spice latte because I like chai. And I was like, okay.
I hate pumpkin.
You'll love matcha. Keep it simple. I know what I like. Suggestions.
Yeah, every time with that sugar cookie
That's
latte,
right.
every time, like the past few times I've ordered it, it doesn't come blonde. Like with blonde espresso, to my understanding, they put blonde espresso in it every time. I don't mind because I like it, but they're adding stuff in it that I'm not even ordering.
Can you explain the ATI? Because we saw the remediation that you were saying on the announcement, but it says it's due before.
Yeah, I was just remediating practice tests.
Yes, yes.
Like the 2 practice tests we do.
We'll remediate the med-surg.
The
You'll
2
also remediate OB, you're talking about OB as well. You remediate the practice test before you take the proctor test.
And this is required.
Yes.
Can you just explain that to the class when everybody?
Yeah.
Okay. Because I don't love.
What practice tests? Because I
Yeah,
thought
I'll
it was
show
A
you.
and B.
The OB practice tests aren't available.
Yeah.
They're not open.
Yeah, it says your
Yeah, it
instructor
will
does not allow you to
let
do this. You can only take one of them.
Is your proctor test scheduled in there?
Neither of them are,
Yeah.
neither of them practice on.
Not the, I don't know if it's there, but it's on our,
I see. It's in
syllabus.
Canvas,
It's
yeah.
in Canvas.
Okay,
But
I'll ask her about
I
that.
had seen it on the ATI. Okay, so pathology. And what does the remediation look like?
So it's called a focused review in there. You will go to, it's not under test, it's kind of in the next one.
Okay.
Improve or,
Improve.
yeah. And you'll and it'll give you the remediation.
Okay.
Oh,
And then we just take a screenshot or,
Nope, that remediation is the topics that you remediate on.
okay.
So they changed that.
Okay.
Well, we don't know how to do
Okay.
it.
Okay, we'll go over it.
Okay.
Thanks.
Yeah, Dr. Barnum told us, like, we haven't been told we're remediating at all. We've been told that if we don't reach, so we have to reach a level 2 in her class at least to not, but if we don't reach that, then we have to retake the exam. Like, we weren't told about any remediation. We were just told if we don't reach the criteria that she said, then we retake the ATI exam after our final on Tuesday.
Okay.
So that's what she told us. Like, we
Okay.
haven't been told. Yeah, I know, I opened it.
Yeah, so I'll go over all that. It's kind of a lot of stuff.
When I checked it
Yeah,
last week, it
so
was nothing but it.
She didn't say anything about us having to remediate. She said that if we have, if we don't reach the level she would like us to, then we can get to retake it to get more points. But if we do bad on this next one, we just don't get that extra point.
So
for-
these.
Yeah, because which one is it that we're supposed to take? Because I've taken this one and I've looked at that one and I just
Sorry, I
finished
wanted
it.
So it's not these targeted, those are those little small quizzes.
Yeah.
Yes.
Um,
Then this
Do
one,
we do a practice one or the, like, this?
no,
so
And this is what we'll
does it
take in
matter
class?
yes, and if it's proctored and you click on it, you're not gonna do
Click
the
on it
wrong
and see
thing.
what
If
it
you
does.
click on it, it will just.
Oh, yeah. So we can take either A or B, and then we can remediate. Let's say we just want to take A, then we remediate it. We can take B, but we don't have to remediate it. Okay.
And you remediate over the first time you take it. So let's say you go to the remediation, but you want to just keep taking it, you can do that.
So how do we need to send any, how do we send it in Canvas that we've done our remediation?
So, remediation.
I know you do a report. Well, I know how to do the report, but.
So you don't need to submit the report. That's for you to know what to remediate on. Usually, I mean, we can look at the report.
I was wondering, I was like, why?
Yeah.
So go, let's see. Have you-
Okay, I've taken a test. Have you taken a test?
You take,
I've taken a test, yeah. Here.
Here, go to
Yeah,
the
yeah.
test.
so, are they,
That's okay, because it's hard. We have, this
oh,
hard.
you gotta get in the last semester. Click on, yeah,
Results.
maybe, well, we'll look
I
at
don't
it.
know, we'll see.
Okay, here, go, Sydney, go to one,
Click on results.
because it shows you, remember what Professor Jones made us do?
Yeah, I think it's the same kind of thing.
No.
Yeah, you have to read reasons, like
Click on
why.
this plus. So
Oh.
this is the exact topic you remediate on. You have to click on the pluses to find out what it is.
For each one that we don't get 100 on, or just above a certain percentage?
You will click on every one of these. Doesn't
Okay.
matter. what
Oh, so.
These don't have anything, so you don't remediate on those.
Oh, okay.
If there's a
So
plus,
let's
there is
say she
something
got a-
under there.
Let's say she got 100% on this one, when she self-remediated.
No, see, these are 100% on, there's nothing.
Each of these topics, you will remediate on.
See, I've got 100 on this one.
Each of
That's
those
not
topics.
close.
Oh, each of these,
These topics.
that's gonna be so many things.
It's
And we
pages and
put
pages.
3 things for each one.
But remember, this was pharmacology. This was lots of things you don't know yet. You should know, you've had all your OB, so it won't look like that.
So then we'll do that many.
Because I'm looking at this, I'm looking at the first one I did, and I did not do good on it.
If it's like that, I will not have time for that.
Fundamentals.
I won't have time for that.
And that's kind of what's really tricky stuff, and a lot of things that we had never talked about.
Mhm. The
So
one we
like
took
there
that-
are
it
things,
had a bunch of
there's
stuff
like
we don't
tons
have
of
on.
things on here.
Yeah, the fundamentals one.
Well, fundamentals, I mean, I usually have a student that do really well in fundamentals.
Well,
But
we
you know it now, right? Yeah, I mean, so,
The problem with the fundamentals though is that it was a lot, the majority was on trach care.
Uh-huh.
We
We
had
had never had
we
trach.
hadn't talked about trach at all, so
So
we
you
were
will.
just like, oops,
yeah.
don't know.
in particular, so mental health, peds, OB, you're getting all of that content in that course. When you get to the last semester, the med surg, you will have had all of that. So look at it kind of in that perspective as well. So I think OB, you should do much better with it. Practice.
Like take a video of us saying.
You know, I would like to.
Yep.
You can shotgun.
You've got, how many different
It's like a VA.
I'll give that to you.
Okay.
And we'll talk about that when we come back. Okay.
That's what I'm thinking.
Right now, yeah.
Oh.
I have what you're looking for.
Oh. I forget you don't have a mind. It's not working. I don't know. What'd you find out,
I'm gonna go over this, but I'm gonna do it kind of at the end of class. Will you make sure? I'm gonna remember, will you make sure?
This is literally
Stop the
loading
about 10
me,
minutes
like
for
trying to
class.
get past that,
For what? I'm gonna go over the
It's the
ATI stuff
apartment.
with
I mean,
you,
I didn't like
but I don't want
track
to
it,
get out of the PowerPoint.
but
because
I'm like,
gonna
bro,
do
it's
it.
literally like that close.
And it's recording, so at the end of class, about the last 10 minutes of class, we'll talk about ATI. Thanks. Read the definition. Okay, so let's finish talking. We're talking about Helicobacter pylori. So how do we treat it? What kind of medications will help with that? It's really kind of what's called a triple therapy, or all of these things are needed to eradicate the H. pylori. So different purposes. They will give, it's this combination therapy can eradicate up to 85% of cases. If it doesn't, they may have to do it again. But the treatment for this is kind of intensive. And so we need to make sure patients understand how important it is to catch it. It's 14 days of this. And if I'm not symptomatic, if I had a little heartburn and now you're telling me that I've got to do all this, patients aren't truly always compliant with it. So it's stressing how important it is and that it can lead to things that could really be life-threatening. So examples, things like amoxicillin, clofazimine, Flagyl. Usually they'll use amoxicillin, but if patients are allergic to penicillin, they'll go to something else. They use an anti-secretory proton pump inhibitor to decrease some of the stomach acid. If we're trying to get the stomach to heal, we want to decrease some of that stomach acid. So cutting down on some of that stomach acid, we want the medication to be able to really have time to be effective in the stomach. And then cytoprotective, so protective of the cells. So things like Carafate or Pepto-Bismol, those are coating. And so they coat the lining of the esophagus and the stomach. So we're trying to let it heal while the antibiotics are killing the Helicobacter pylori. Okay. These are some pictures of some ulcers. My husband's like, you like really gross pictures. I'm not sitting there watching TV looking at things that, like the colon. And so these are gastric ulcers in the stomach. Again, they kind of look like canker sores. Ulcers, they can be very deep. They can have bleeding. And this is a duodenal ulcer. Again, past the pyloric sphincter from the stomach into the small intestine, can really damage either the duodenum into the small intestine or even that sphincter that opens and closes. And if it's damaged, it doesn't open and close correctly. So these ulcers are an evacuation or a tunneling or a sore or an ulcer in the wall of the stomach, the pylorus, where the stomach opens to enter the small intestine, the duodenum, small intestine, or the esophagus. Any of those can have those ulcers. And they can result from a pylori. There's also a syndrome called Zollinger-Ellison syndrome. It's basically kind of a genetic thing where people naturally make more stomach acid than other people. So they may be more predisposed to having things like ulcers, stress ulcers. And when we think about stress ulcers, we think about decreasing stress, anxiety, all those things, but think about physical stress. People that have infections or injuries, or the body is working really, really hard, like autoimmune diseases, have increased physical stress, and the body makes more stomach acid. So our patients that are in the hospital who have various serious body is trying to heal, burns, shock, sepsis, patients that are intubated, they're always going to be on a proton pump inhibitor. We are trying to decrease the risk of that increased stomach acid damaging the esophagus, the stomach, and the small intestine. So that is going to be something that we're going to see. Predisposing factors, who is at an increased risk of these? It could be hereditary. Again, we could have that Zollinger-Ellison syndrome where our body naturally makes more stomach acid. It could have your blood type O. Now, they have some evidence that says that certain blood types are predisposed to make more stomach acid. Smoking, alcohol, NSAIDs, emotional stress, physical stress, all those things increase the risk of ulcers. Okay. So what kind of symptoms? Patients may have pain. Yes.
Quick question. So for the type O having the predisposing factor, I think I read that it said that it also like exacerbates the signs and symptoms of O. Is that true?
It could. Yeah, it could. It could. Patients may have stomach pain. They may have back pain. Okay, again, it radiating in those tissues. Excuse me. They could have vomiting. They could have gastroesophageal reflux, constipation. Yes.
Is the back pain going to be like lower back pain, mid, like, or upper?
Kind of mid, kind of refractory from the stomach.
Okay.
Yeah. Could be bleeding, again, vomiting, diarrhea. Okay. Medical management, those lifestyle factors we talked about, but also medications. Could be on an H2 inhibitor, could be a proton pump inhibitor, could be antibiotics if we're talking about H. pylori. Could have surgical intervention. If we have an area of the stomach in particular that is so eroded it's not going to heal, they may remove that part of the stomach. They may remove part of the duodenum. Okay? If they have something called intractable ulcers that are not healing, okay? Again, our fear is that they become so deep, I guess, that they eat through the lining of the stomach or small intestine and leak out into the peritoneum, and deadly for our patient. So they may remove parts of that. Those who fail to heal in about 3 to 4 months of treatment, again, that means the ulcer is getting bigger and bigger. So they can do something called a vagotomy. Anytime you see an otomy, it's a removal of something. They can remove part of the stomach. They can remove part of the small intestine. And that's if ulcers have deteriorated so much and gotten so big that they're just not healing. Pre-op care is preparing the patient for any diagnostic testing, so any GD. Okay? We don't need to be, in particular, have any kind of prep as far as bowel prep. If we're doing it goes through the mouth and goes down, but we do need to be NPO. Okay? Limiting oral intake, again, in NPO, maybe in clear liquids and then nothing to eat or drink. Again, patients could aspirate. Could be that we are clearing and emptying the GI tract, particularly if they're going in and looking at the large parts of the distal small intestine. So what kind of test are they doing? What kind of prep for that? Could be that our patient may need an NG tube. So maybe they have bleeding, okay? And our patients that come in for GI bleeding, so stomach ulcers in particular, they're going to have an NG tube. They're not going to have anything to eat or drink, and they're going to be suctioning that out. It's going to be dark to almost kind of a black color, because many times that's old blood that's sat in there, okay? And so while we are letting it heal, while we're taking PPIs and decreasing stomach acid, we want to suction out anything in there like stomach acid that could be being produced. We could be enema sauna to clean out the colon. That could be a prep. We want to monitor for any complications after an EGD or after any type of test. Bleeding, perforation. Again, perforation of the ulcer means that it's broke through the area, leads to peritonitis. Pyloric obstruction. So leading from the stomach to the small intestine, kind of that part that opens. If it gets so edematous from an ulcer or things like that, it could get so edematous it won't open. So that means that it's blocking things leaving, and patients could be having lots of vomiting leading from that. So an NG tube again. We said perforation means rupture of that ulcer, it's gone all the way through and led to peritonitis. Okay, so what do we see when patients have peritonitis? Again, a perforation, the contents of that area lead out. So is it the stomach? Is it the small intestine? It's all going out. We're going to see sudden onset of pain, severe pain. Okay? So again, thinking about things like the stomach acid, or even that acid that's just left the stomach, leaking out into the peritoneum, those tissues that are not made for that, we're going to have pain and burning in that area. Also, a characteristic sign of peritonitis is a rigid board-like abdomen. The tissues in the become kind of stiffened and paralyzed by those damaging substances. So very hard stomach, very painful stomach, shallow rapid respirations, pain, okay, free air in the abdomen. So again, when they do an x-ray, they can see that there is lots and lots of that's in the stomach and the intestines that has pushed out now into this area. And so they'll be able to see not only contents, but lots of pressure and air in there. What do we do if there's a hemorrhage? That patient is bleeding. Now we think about blood, but also we need to think about fluids that we're losing from the vascular system. If that ulcer is eating through there, we're also damaging blood vessels, and we're going to have bleeding. And so we're going to see signs that the patient is bleeding, okay, internally, but it's leaving the vascular system. They're at risk of fluid volume deficit, not enough fluid in the vascular system to support cardiac function. Just like if I were dehydrated, just like if I were in an accident and lost lots of blood, okay? Low fluid in the vascular system, tachycardia, tachypnea, increased respirations, hypotension, the blood vessels are going to open up to help push that fluid around to get it oxygenated. The tissue perfusion, because I'm not going to be able to have that oxygenated blood get to where it needs to go in the right amount of time. Patients can have signs and symptoms of not getting enough oxygen to tissues, change in levels of consciousness. I could lose the consciousness. I could become confused. My skin could get very pale. Tachycardia, my heart's working really hard. I'm they're trying to get enough oxygen in, okay? Skin color, temperature, cap refill, turgor, all those things that we look for. Blood flow, vital signs, urine output becomes very, very decreased or absent because the kidneys aren't getting enough oxygen to be able to function. They can't do their job. Okay? A loss of 1,000 liters, 1 liter of blood, usually causes a 10 millimeter drop in blood pressure and a 20 beat increase in heart rate. We're going to see changes, okay? We're losing blood. We're going to see changes in the heart rate and blood pressure. So how do we manage it? We want to get them some more fluids in the vascular system. We're going to start an IV, okay? We're going to put more fluids in there, and we think, well, that's not necessarily what they're losing, but it is going to help propel the oxygenated blood vessels, that the blood cells that are in there around. We're going to monitor vital signs. Are what we're doing helping the patient? Are they getting worse? We could also things like blood or clotting factors. Whatever they're missing, we need to replace that. We may do something called a gastric lavage. So what this is it's where we're going to wash out that peritoneal cavity. We're going to try to get everything out of there that shouldn't be in there. So they can put an IV in. The book talks about a large bore, very kind of a big IV that, or not an IV, excuse me, an NG tube that is very wide, so holds lots and lots of fluid. We're going to stick that down And it's gonna leak out of the stomach into the area in the peritoneum. And it's gonna flush all that out, normal saline, flush all that out, and suction it all back out, okay? If they are having lots of problems where they think they need to go in there and they need to surgically repair that, they can even do this in surgery, open up the stomach, put all that fluid in there, suction it all back out. Anticipate a transfer to the critical care units. They're not hemodynamically stable anymore. So we're having problems with fluid volume, with blood cells, with hemorrhage, all those kind of things. So they're going to repair that, get them stable, move them to critical care to be watched more closely. Okay. Questions? Let's move on to the large intestine, okay? We've left the small intestine where we said that there is absorption taking place. So we said the large intestine is responsible for compacting the waste products, for pulling in fluid, okay, and for peristalsis, moving things along to leave the body. We have to have a clear pathway, okay? If we look at the large intestines, okay, they are going to, the small intestine is going to join, okay? And we have the appendix that hangs from here. We're going to talk more about the appendix, but upcoming. But the appendix is from the distal part of the large intestine, the small intestine, again, joining into the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. Okay? We need movement and peristalsis. We're going uphill, right? The place that patients are more likely to have things like constipation and pressure and ulcers and kind of tearing of tissue is in the sigmoid area. We have put fluid in to move it along. We've now pulled fluid back out in things, and we should have it very compact here. This is where it tends to sit. And patients can damage blood vessels here. They can damage nerves here from having constipation for a long time, from stretching that area. We can have internal hemorrhoids in this area, lots of bleeding. So many times if patients are having rectal bleeding, if it's bright red, it's coming from this area. It's not been very long, it's fresh. If they're having dark blood, we look at the stomach and areas that are more distal to the rectum because it's old blood, it's sat in there a long time. So truly, if patients are having any rectal bleeding, the doctor may say, what color is it? What does it look like? Okay. So let me do this. I usually have this over there and it really messes me up now that they move it back over here. Okay. I don't want you to get confused with some of the abbreviations and terminology in the book. So we've heard of IBS, but there's also IBD. Okay, very, very different. Irritable bowel syndrome could be constipation, diarrhea, or combinations of that. Okay. Okay. This is a movement disorder, functional disorder. So it means that the tissue integrity in the large intestine isn't damaged. It doesn't move the way it should to propel things along the way. It either moves too fast or too slow. So there's an interruption, there's either an interruption or a problem with the movement, the peristalsis. Okay, the tissues are fine. It's the movement. Okay? Irritable bowel. Inflammatory bowel disease, we think about being Crohn's disease or ulcerative colitis. Inflammatory bowel disease is mechanical. There's a problem with the machine, right? So the machine, being the large intestine, there's damage to that. There's tissue damage, okay? So these two diseases aren't a movement disorder. They are damaged into the tissues of that can lead to things like bleeding, lack of absorption of nutrients. Some can be constipation or diarrhea simply because the tissues are damaged. So what we're going to really talk about in detail are Crohn's and ulcerative colitis. Very different from irritable bowel syndrome. What we would do to treat this would be give medications that either increase the movement of the peristalsis or decrease the movement of peristalsis, as well as increasing fiber and fluids and exercise, all those things. This is many times an autoimmune disorder, okay? So we look at it and treat it with things that like immunosuppressants, inflammatories, and we will continue to watch and see how progressive this tissue damage becomes. It can lead to things like colectomies, removing part of the intestine, and then we're also going to talk about how these two are very, very different. So we'll compare those two. Okay. So let's look at some disorders, inflammatory disorders. Could be inflammation due to infection. It could be due to increased pressure, could be due to bacteria. These things can affect parts of the body. And so I'm just going to touch on these a little bit. There can be problems with inflammation in the anal or rectal area. And again, I just want to kind of talk about terminology. There can be an anal rectal abscess. So an area between the anus and the genital area that becomes very irritated and eroded, and an ulcer can form and it can get very deep. Many times this will happen if patients are constipated and they have a lot of pressure in that area. It can also happen when patients may be incontinent of stool or urine, and so the outside skin becomes very irritated. So this abscess or this infected part is on the outside of the tissue, but in that area where if there is a break in the skin and irritation, that there's a lot of bacteria down there, and it can really get in there and cause an abscess or a buildup of infection. So they may go in and kind of open up that abscess and drain it, and we may get that patient in our unit and they may have it packed. So something called iodoform, it's really thin, kind of looks like shoestrings almost, and it has medication on it. You kind of pack it in there with one of those long Q-tips, and a couple of times a day it absorbs the infection and you change it. And I'll tell you a funny story about this. I got a report from a nurse many years ago, and this patient had an abscess. No, that's not funny. It wasn't funny for him. The funny part was that the nurse I was getting a report from said, we have to pack it. We have to change the packing a couple of times a day. So I go in to treat this patient and I see this abscess and there's no packing. And I thought, she didn't pack it or else it fell out. And the patient tells me that she's been packing his rectum and not the abscess. So anatomy is extremely important, that we know where this thing is and where we're packing. If there's a hole there, it doesn't mean that's where the problem is. We don't just pack things up in there. So I will never forget that, that we know where it's located, right?
Love that.
Other things that can happen due many times to pressure and constipation, or something called an anal fissure. A fissure is a tear. Okay, so if a patient has a fissure, an anal fissure, inside the rectal area from pushing and constipation. There could be tears in that area. They could have bleeding and pain and irritation. Patients complain of itching. So anti-inflammatory cream and things like that to heal it, and also preventing constipation is important. Patients can also have inflammatory disorders, and we kind of mentioned this about the stomach. Many times it's described as a gastroenteritis, nausea, vomiting, diarrhea, sour stomach, and it's something we eat. So food poisoning many times, things like salmonella and staph and coli, botulism. Some of these bacteria like botulism could be deadly. So botulism comes many times from canned food that's not sealed properly, and like home canned food, but it can also happen processed canned food. So if you ever get canned food that there's a big dent in it, or there's a crack in it or something like that, it might not be sealed really good, shouldn't eat it. But also home canned food, if it's not sealed properly, bacteria in that food can build up and patients can die from it. So that's a huge thing. E. coli, bacteria that is normal in our large intestine. It helps to break down food. It helps to break down anything that could be in there. It's a normal good bacteria. It's not a normal good bacteria if it's ingested into our stomach, okay, or in our urinary system. We'll talk about that coming up. So these can make you very sick. We want to avoid things like food that's not cooked properly or food that's not refrigerated properly. It could be looking and watching things like recalls of food they talk about on TV, washing fruits and vegetables properly, all those things to prevent contaminated food, washing hands before we eat food. And then if they're having vomiting, diarrhea, vomiting up blood, lightheadedness, anything that could indicate dehydration, we need them to come in. So inflammation of the appendix, and we looked at where that was at. It was kind of the distal area where the small intestine and large intestines meet. We're really not sure 100% what the appendix does, but it seems to have some type of an effect on our immune response. But we can definitely live without our appendix. It is a pretty common surgical emergency, happens many times in young adults, even preteens in that area, but it can happen at any age. What we're concerned about is inflammation causing pain, can cause you to have your appendix removed, but we're concerned about it rupturing because it is infection and it can go out into the peritoneal cavity. And what does it cause? Peritonitis. It's peritonitis. And so we want to prevent that. The older a person is that has appendicitis, the more likely it is to rupture. So it can be very serious, particularly in an older person. Cause is obstruction of the lumen of the appendix by a fecal lift. You know what a fecal lift is? It's a little piece of poop. And so a fecal lift can get caught in that area and obstruct it so that the contents become trapped and they can produce bacteria or proliferate bacteria that's already in our GI system, causing pressure, and that pressure causes pain, and if it's not treated, it could rupture, okay? So many times when patients are having pain and symptoms, fever, nausea, vomiting, those kind of things, it is an inflamed appendix, okay? What patients complain about many times when it ruptures is an immediate relief of pain, but then it starts again. So that pressure is what's causing pain. 1/3 of patients with their appendix has no obstruction. So again, most of the time it's due to that fecal lift, but sometimes it can be twisted in that area, anything that traps the contents in there. We talked about signs and symptoms, diagnosing it. Look at symptoms, but they'll also do a CT scan. That's most common, other than an X-ray, because we want to see not only the kind of the outline of it, but we also want to see blood vessels, those kind of things. So they're looking to see, is that area inflamed? Is it enlarged? Is there changes in blood flow? All those kind of things. So management is surgery. And it can either be a laparoscopic surgery or an open surgery. We prefer laparoscopic, less time in there, less healing time, less risk for infection. If the appendix has ruptured, they're going to have an open because they do that gastric lavage in there to wash out the peritoneum. They're going to be on IV antibiotics to prevent the bacteria that's got into the bloodstream from kind of proliferating. So it's much more serious if it's ruptured. Complications, we said peritonitis. So again, patients many times not only complain of pain in an area, McBurney's point, I guess McBurney discovered it, but it is an area from the umbilicus directly to the appendix. Where's the appendix located? Right lower quadrant. So kind of midway between the appendix and right lower quadrant is where it's most tender, and what they will assess is rebound tenderness. Rebound tenderness is when the physician will push lightly on it. When they let go, that's when the patient has the most pain because of inflammation. So inflammation causes that area, once it has been kind of pushed down and occluded, to kind of bounce back. And that bouncing back of that causes a lot of pain for that patient. Again, so nausea, vomiting, can have fever. Yes?
Is the surgical incision gonna be like in the right lower quadrant, or is it gonna be?
So what they do, if it is a laparoscopic, you have 4 little incisions. They're going to go in, kind of 2 of them, to have one area that holds the appendix, the other one that kind of clamps it off and pulls it out. They're also going to have one that goes in that's a light, and one that goes in that kind of puts air in there that blows it up so they don't damage any other areas. So those are, I'm trying to think where mine are.
No, I have a appendix scar too, and it's the one, like, I have a right lower, but I had a friend that, like,
I have a
laparoscopic
one.
Yeah.
You can still see the one under my belly button, but you can't see the other little ones from where
Like
they
mine
went in with the probes.
Right.
Like mine ruptured, but they did it laparoscopically.
Did they? Okay.
Which was so weird, 'cause you said it was gonna, like, I heard you talking, it's like, oh yeah, it'd be open, but mine ruptured, and I have like just 3 little scars, they did laparoscopic.
Good.
So like, I went in Monday, was there Friday.
One.
I was there on Monday, I was there on a Monday, and then went in on a Friday because it ruptured.
Wow.
But yeah, I don't know if it was like, would they do like a laparoscopic even if it ruptured on like a younger, maybe?
They may, and so that's a good point. So Catherine said that with a rupture, they could do a laparoscopic. Many times what they do is they don't really know it's ruptured till they go in, or even if they do and they caught it early, they want to try to do laparoscopic. So even if it's not ruptured, what you're going to do is you're going to sign a consent that says we're going to do laparoscopic, but if there is more area of damage, we're going to have to open you up. We're going to do an open. And so they'll go in, and particularly if it's caught, if it's small enough to be able to kind of pull it through those laparoscopic holes. If they don't see a lot of damage in the peritoneum, they'll do it laparoscopic. Okay. Yeah, but if there's too much damage, they'll do an open. And an open could be a larger incision, so not thinking of the little small incisions, but more of a large incision, and that could be kind of the lower quadrant area. Yeah. So some of the considerations of appendicitis, peak incidence, again, is kind of that preteen, teen area. It begins kind of as a low, steady ache and increases in severity. Again, with that, a fever, can come nausea and vomiting, and these symptoms can really progress over a couple of hours, even a day, to the point of where someone is needing help. It progresses over about 4 to 6 hours, right lower quadrant. The symptoms we talked about, sudden pain relief, may indicate a rupture, okay? And then it leads to and the patient can become much, much more sick. Diagnosis of clinical signs, what kind of symptoms are you having? We're going to do a CBC. We're going to look at your white blood cell count. Again, inflammation, infection can indicate increased white blood cell count. They're going to do an abdominal sonogram, or they're going to do a CT scan. They may do an exploratory. So maybe it looks a little suspicious, but they don't know if that's what it is. They may even do a laparoscopic surgery to go in there and see, is that what it is? Is there something else going on? That rebound tenderness we talked about occurs at that McBurney's point.
So why is,
because it's infection in there and it's rupturing out into the peritoneum, that peritoneal cavity, it will leak into those tissues, go into the bloodstream. Yes. And so here's kind of that point, that McBurney's point between this right lower quadrant of the umbilicus where you have increased pain. Then we got some lovely pictures. This is a beautiful, intact appendix. Okay. Compared to a ruptured appendix. Okay. So the other one, a little bit of edematous, has this one is ruptured, eaten through the appendix, and it is leaked out all that infection into the peritoneum surrounding, again, the intestines. Overview of what we talked about, peritonitis, okay? Rigid board-like abdomen, okay? Severe fever, increased heart rate, increased blood pressure, okay? Decreased bowel sounds. Patients can have dehydration, shock. Again, we have ruptured that area. There's lots of blood vessels. We're going to be losing fluid. Nursing care, fluid balance, decrease the stomach distension. Okay, patient's going to be NPO. We don't want more stomach acid and process and all that stuff. Prevent complications. So again, NG tube on the end of the bed, we want to get them up and move them. We don't want complications of immobility. Pain relief is important. Sometimes patients will get in a position called a position, and that really helps decrease pressure on the abdomen, kind of that fetal position. Patients may, especially if they are having a lot of pain, be in that position. Pain medication, decreased stress, quiet environment. We said NG2, IV fluids, rehydrate, replacing some of those electrolytes, particularly listen for bowel sounds, low bowel sounds to no bowel sounds. Could be not only what we think about as peritonitis, but peristalsis. That's decreased movement of the intestines. When all this fluid leaks into the peritoneum, we said that that area, those tissues in the peritoneum, become very hard and rigid and from inflammation. That's going to put pressure on the intestines. So those bowel sounds are going to be very decreased as well. Signs and symptoms of dehydration, all those kind of things. And we talked about they may go in there and they have to do that gastric lavage, wash that out. They may have to do surgery to the area that's ruptured or to repair the appendix or whatever has leaked out into the peritoneum. All right. Symptoms we talked about. It's life-threatening. And again, some other kind of diagrams of symptoms.
And you said peristalsis is the ability for the intestines to move things?
So when we listen to bowel sounds, those bowel sounds are peristalsis, yes.
Okay.
The movement of the intestines. Okay. Again, some lovely graphic pictures of the fluid that's in the peritoneum that shouldn't be. All right. Pain management, ventilation. Again, anything we're doing to the peritoneum, inflammation is causing pressure on the diaphragm. We want to make sure patients are able to breathe. If we're having a lot of pain, we're going to shallow breathe anyway. So it could be making sure they get enough pain control so they can take those big deep breaths. Could also damage, so we've got kidney injury, thinking about if we're not getting oxygenated blood to the kidneys. And it could affect other organs. We want to make sure they're getting good nutrition, and that could be in an IV. That could be through means, so parenteral nutrition through an IV. They're also at risk of blood clots, right? So not as much mobility. So even though they have an injury, even though that they are in pain, we can clamp the NG tube at intermittent periods. We can give them pain medication. We can help them get up and move and walk. And they also may be taking medications like Lovenox or heparin to prevent blood clots. So all those things possible with decreased mobility. All right. So in the large intestine, we said particularly that pressure Stretching of those tissues is in the area at the bottom because that's where stool is the most condensed. And if we have constipation, it kind of sits there. This can lead to something called diverticula. Okay? The diverticula are due to pushing and pressure, kind of like if we had something and we kept stretching it, then that tissue in that area would become kind of flabby. Okay, so this is what happens with the diverticula, with the tissue in that area. These diverticula are like little outpouchings that happen in the sigmoid colon because we've stretched it and stretched it from constipation and straining and those type of things. And it really happens much more frequently as patients get older. But if they have problems that relate to constipation, like irritable bowel with constipation, they may have this as well. So the diverticula, these little outpouchings, are not problematic in themselves. They are a result of things like pressure and constipation. So what we want to do is to make sure that they don't become irritated and inflamed. Okay? Again, it looks like something off Star Wars, but this is kind of the transverse area. We can see that outpouching there. So not necessarily problematic. It's just a stretching of that tissue that happens. So the diverticula are those sac-like structures that pouch out from that intestinal wall, again, as a result of things. We can see the inside of the colon here, and they can look with a colonoscopy even if they go in to look, and they can see these little pressure areas that have kind of pooched out there, and say this patient has the diverticulum. Diverticulitis is where those diverticula are present without inflammation. So diverticulum are kind of the outpouchings. Diverticulosis is where they become very, very numerous in that area. So it happens over time. It's more of a chronic problem with pressure and constipation. When it becomes inflamed and irritated, that's called diverticulitis. Again, itis is inflammation. So peritonitis, appendicitis, diverticulitis, inflammation of those diverticulum. And they become very red and irritated and painful. Patients have a lot of left lower quadrant pain from that sigmoid area, and we're afraid they could rupture. What would they have then? Peritonitis. So treating diverticulitis is very important. Okay? Not everyone who develops these diverticulum have diverticulitis. Okay? Again, if we notice these diverticulum, it's that patients are educated about how to prevent constipation, fluid, fiber, exercise. Okay? As we get older, it's more common. Okay? Much more common in this area, but particularly in this descending colon, where stool sits. Okay? What are we going to teach? We want to teach them to increase fiber, but not when they have diverticulitis. It's already inflamed. We don't want to make them more constipated. So if they are having an exacerbation of this diverticulitis, the inflammation of the area, pain, inflammation, we want to increase the amount of things that are going to cause irritation. So low fiber, low residue. Residue are things that have seeds and nuts and hard particles that are hard to digest. And so talk about a meal plan as well. What kind of foods would I eat, right? If we just say low fiber, low residue, they're going to, I don't have a clue what that means, or they're going to go home and eat what they usually do, right? So helping them plan out a meal of things that are not going to have nuts or seeds or any of those things that could get stuck in those diverticula and cause more inflammation. After they've been treated and decreased the pressure in this area, antibiotics for any type of inflammation, bacteria that could be causing this, we're going to progress them to increase their fiber, right? We're going to talk about increased fluid, increasing fiber slowly, foods that have fiber, fiber supplements, to all the way while they're maintaining this to prevent diverticulitis from continuing with meals that have fiber. Yes.
So diverticulitis does the 3 weeks low fiber, and then it hopefully turns back to diverticulosis, then it turns back to just maintaining it?
Yes.
Okay,
Yes, those pouches will never go away,
okay.
but we want to do things to prevent, again, things from irritating, inflaming, prevent constipation, anything that could get kind of in there. Again, patients that have diverticulum doesn't necessarily mean that they're going to have diverticulosis. So it's not thought to be purely a diet thing. So it's not thought that people that have these diverticulums should totally avoid things that have, nuts and seeds and all that. Because many times what happens is they continue to have constipation, they continue to irritate that area, and then it blocks off or walls off those diverticula, and bacteria proliferates in that just from what we carry in our stool. So low residue diet and things to prevent it extending. There is an exacerbation, but it won't simply prevent it from developing. Yes.
If something is stuck in one of the little diverticula, how do they get that out?
Well, it depends on, many times if it's irritating and inflamed and they give anti-inflammatories, antibacterials, it can cause those areas to be less inflamed, so it can kind of come out on its own.
Okay.
Usually.
So normally it just something sits there and it gets inflamed, so it's sucked in and then.
Yeah,
Okay.
yeah, and it's usually from that lining on the inside that kind of walls it off and blocks it there. Do you have a question here?
I was just gonna ask if, can the diverticulitis just last longer than 3 weeks and return into diverticulosis, then what should happen?
So can it never, if it doesn't get better?
Right.
If it doesn't get better, they may you try to use other things, maybe using anti-inflammatories, things like that. If there's so much damage and it continues to damage, it could actually lead to part of the colon being removed. Yeah, it can lead to having a colectomy, removing part of it. Yeah. We said it becomes complicated when those small out pockets become inflamed, and so it walls them off and blocks the abdominal pain, particularly left quadrant pain, fever, nausea, vomiting, things that we associate with inflammation. Also looking at white blood cell counts. It could be a sign of lower GI bleeding as well. So if they have perforated, or if there's so much irritation, there's bleeding, again, bleeding in the stool. We don't want them to perforate and have this. We don't want abscesses where that infection's walled off and it continues to get worse and worse. Okay. Could have bleeding, hemorrhage, could have an obstruction. There could be so much inflammation that it completely blocks off the intestine, and patients end up having a bowel obstruction. And we'll talk about that again, very serious, because we can only hold so much stool in there, and it can again cause more and more pressure and damage the intestines. All right, let's go ahead and take our break at this point.
Look at that.
The Crohn's disease video would play, but the ulcerative colitis video says that it's a private and that your administrator is.
Okay, I'll look at that and see if it doesn't open, maybe I can replace it.
I think it's just like the privacy on it or something, it's
Okay.
long, but I just want to let you know.
Thank you, I appreciate that.
The second one works, but not the first one.
Okay.
So I have a question. So I've seen like IBS, like Todd written down as like IBS, like gosh, like C or,
Right.
C or D. So I didn't want to like interrupt like the lecture to ask. So like, I see it written as like IBS-D, so that's different from IBD.
Right,
Okay.
right.
So it's just,
Yes, yes,
Yeah, because I've seen it like written down like different ways,
yeah.
but like but it's two different things.
Yes, and IBS is much more common. That peristaltic movement, can be stress, could be lots of things. It's more continuous as they diagnose someone.
I'm just going off like my personal experiences, sort of, but like with IBS, like with if they give like medication for it, is it like with my experience, I had to take it before I ate anything? Like if I had like, before I would eat lunch, I would take it, before I eat dinner, I would take something. Is that normally how, or could it be like a once a day kind of deal? Or does it really just depend?
It would depend.
Okay.
Depending on how severe it is, would also depend on, you know, what kind is it? Is it something that, is related to kind of more foods that you eat? Is it related to an autoimmune kind of problem?
Gotcha.
Something like that.
And
So,
can IBS just like go away? Like, just like that, it's like you have it, and then suddenly it's just not as bad as it was?
it can.
Okay.
Yeah, really depending on kind of what causes it and that kind of thing. Yeah. It could be a neurological problem, so patients that have problems with the nerves that kind of innervate, that help with peristalsis. So lots of different disease processes that kind of go along with that.
Yeah. Like I knew someone, like I couldn't remember, I would eat a vitamin. Would be done. And then it just randomly unplanned.
Yeah.
So it just kind of just, like there were many things that could cause it, and there were many things that could just end it.
Yes.
Gotcha.
Yes. Then a lot of times some of the things could be kind of those life. So we change what we eat, we change the quantities we eat, taking medication before we eat, all those kind of things.
Gotcha.
Yes, definitely.
Okay, that makes sense. I just didn't want to confuse the two.
I know, because they look very, very similar.
Right, I was like, having a D and a B next to each other is like the worst thing in the world.
Yeah, you're right. So it could be C, it could be diarrhea, or sometimes they have it as kind of IBS.
C commercials with this.
Yeah.
Sometimes they'll have C/D, so that could be alternating constipation and diarrhea.
Yeah, 'cause like that's how I always see it written down. I see IBSD, and I was like, okay, but that's different from IBD.
Yes.
Okay.
Yes.
So, if you have IBC or IBD, would you take a different medicine?
Yeah.
So what if you have IBD and CD?
You're just screwed then.
Sometimes.
Count your blessings.
Yeah, sometimes what'll happen is they'll take medications to kind of increase the ability of the nerves to kind of help with the muscles. Because some of those patients have diarrhea because through the sat there for so long from lack of movement, that all of a sudden there's so much pressure they have diarrhea. So they're related to each other a lot. Many times that diarrhea can be caused by constipation. And you know, from that constipation irritates the intestines so much that then after they eat, it just moves through really quickly. And yeah.
Dr. Lowe, the ATI practice
Yes.
exams were.
Yeah, that's the one. I had to make sure it's close for this class and
Yeah.
open for open.
Those,
Okay.
they none of them were open.
Okay.
And that's all. And then I dropped. I got a 65. Yeah, that's what I think I'm gonna do. Because like, but some of my personality had to do. She was acting weird. I said, if they wanna do this, I said, tell them. I was thinking like this. What are you talking about? But no, I told you, I would take a week, or
I would.
Then I'm not doing this one.
so you have to choose,
Beggars can't choose.
Right, it's on Monday, it's on Monday.
If I were to have this be the syllabus before we started this class, I would never we said never after ATI exams. And then we did, and then last week, we had how am I supposed to study for this? Because the remediation and that is a due before. So how easy is it to study when your exams you could have done this.
I'm still remembering.
I'm gonna cause problems. Very angry when she says the number.
It's okay, I don't run into you.
I said, y'all got to go.
I don't even know like how you're here right now.
I said, just say that. I know, you really want to say right now.
See, I know my apartment and they say, I let them stay down there. I go back.
Well, I said, you're lucky it's you, or else it would, like, no, you'd be hard to kick that out.
No, like this one boy, I literally went to sleep and he slept down there. I didn't
But yeah, you can stay here, but I'm not staying here.
Okay, I'm gonna go ahead and get started back so that we have time enough to talk about ATI. So we talked a little bit about IBD, inflammatory bowel disease. And these are chronic and progressive. They don't happen overnight. And the two really distinctions are ulcerative colitis and Crohn's. So we're going to talk about kind of some things they have in common and how they're very different. The symptoms that they may experience may be similar. Abdominal pain, diarrhea, rectal bleeding, fever, weight loss, fatigue. So thinking about both of these are damage and deterioration of the lining. Now in a minute, I'm going to talk about where they occur. So that would determine where there would be damage to those tissues. Okay? Tissues can cause things like malabsorption, problems with peristalsis or movement if they get down into the muscle and the nerve, could cause bleeding. Okay? So long-term complications, anemia, perforated bowel, leading to it's the last time, I swear. Malnutrition, malabsorption, fistulas, so like a tunneling, abscesses, infection, osteoporosis, not absorbing the calcium, increased risk of colon cancer. I skipped a couple of those because I'm going to come back to them in a minute. What is the difference? Ulcerative colitis happens only in the colon, the large intestine. So those are my problems in the large intestine. Peristalsis, okay. Continuous inflammation. So the entire large intestine is very irritated and inflamed. Okay. Again, affects movement and affects the ability to move the stool, compact the stool, all those kind of things. Mucosal and submucosal involvement. What that means is it affects the lining of the intestine, but then also down into the middle layer. When you get down into that middle layer, you get to the blood vessels and you start bleeding. Fistulas are rare. I'm going to talk about a fistula in a minute, but it's a tunnel that goes between the intestine and either another organ or from the intestine. That's what I got. Or a tunnel that goes from the intestine to the outside of the body. So yes. And it's because it becomes so inflamed and kind of large that whatever's eating through it is going to eat right through it and the thing that it touches. Okay? It does sound like something from Star Wars though. Very severe diarrhea, okay? Because the area that's supposed to be compacting the stool isn't working. Okay? So things are just going to fly right through there. We haven't had a chance to pull the water out. Crohn's disease. It's also known as regional enteritis. Enteritis is inflammation of the tissues. Regional meaning that it doesn't just happen in the large intestine, it happens in different areas. All the way from the mouth to the hiney, okay? From the mouth to the rectum. And it has what are called skip lesions, which means it's not continuous. It could affect this area, then this area, then this area, then this area. So they're in different areas. Okay? This is extremely problematic because not only restricted to the large intestine, but it could get very severe symptoms in other areas. So ulcers in the mouth, the throat, the stomach, problems with absorption in the small intestine. Those things we're not going to see with ulcerative colitis. The pathology extends through all the layers. And we think, well, that would cause bleeding because it goes through the middle layer. But what it does is it kind of erodes all the way through, and it kind of sometimes, scar tissue blocks off those blood vessels, but it has much more increased risk of peritonitis because it goes all the way through those areas. And because it does that, these fistulas are more common. This tunneling or eating through the intestine or where it is going out into and attaching to whatever's next to it. So let's say that, I don't know, that my bladder and my part of the intestine that was has Crohn's lesions are right next to each other. It could eat through the intestines and through the bladder, and you could have your patient that is peeing out some poopy pee. And we know that's a huge infection that could cause kidney failure, all those kind of things. But they can also have things where it eats into the liver, causing lots of bleeding, or eating through the intestine that's very large and edematous, all the way through the outside of the skin. And so they could have little sores on the outside of their stomach where poopy's coming out. I'll tell you a little offshoot from this. Last year, they wanted to come in and video the classes to make snippets to put on the website, and all I did was talk about poop, and they said, we don't any of this. So
You picked the wrong day, my
I know. So those fistulas are common, less severe diarrhea, because it's not continuous. It's not continually affecting the whole large intestine. So both of those, again, could have risk of so much damage that we could have to remove part of the intestine. With this one, you know, it's not just the intestine. So there could be damage anywhere along the pathway. Okay. Here's Crohn's. This is an area that has inflammation. So it has these kind of bumpy, it's what's called a cobblestone appearance. It has these little bumpy blister kind of things all over it. And past this, there may not be any. And then past that, there might be some again. So that's an area that has that. In contrast to ulcerative colitis, that has eroded all of those tissues, and not just those kind of skip bumps in there. It's eaten through the entire mucosa and submucosa of the entire thing. So it looks like. How do we manage it? Dietary modifications, again, if we have areas that are inflamed and bleeding or irritated and causing pain, we're going to change what we're eating. We're going to decrease the residue in our diet, decrease the fiber, because it needs time to heal. Okay. Medications, we're going to use anti-inflammatory, particularly medications that decrease inflammation, that can be autoimmune medications. So lots of these medications in particular that have the B at the end, Remicade and Infliximab and all those kind of things that they have lots and lots of commercials for. They use them for lupus, they use them for ulcerative colitis, they use them for psoriatic arthritis, all those kind of things that we hear about. Those can decrease our immune response, and sometimes that decreases inflammation. They can use other medications, again, that have an antibiotic property. They can use corticosteroids short term. If I have a exacerbation, this is going to decrease inflammation the quickest. And then surgery may be necessary if that's so damaged that this doesn't work. We may have to remove part of it. So what do we want to recommend? Avoiding smoking, avoiding alcohol, avoiding NSAIDs, avoiding foods that increase stomach acid, that are going to cause more irritation, fiber-rich diet. What kind of foods do I eat? Increasing fluid, increasing exercise, and to also incorporate some things that are good for you in your diet. So this talks about omega-3 fatty acids. Those are the kind of fatty acids that are said to have an anti-inflammatory property. So eating things that are nutrient dense, we get enough of those things we need, but also some things that could decrease inflammation in the body. Fish is one of those things. Okay. Corticosteroids, why are they so bad? The good, the bad, and the ugly. Okay. Good, decreases inflammation, does it very quickly. Okay. Bad is there's a trade-off of that can deteriorate parts of the body. Okay. the patients that have anti-inflammatory, autoimmune reasons should take those autoimmune medications every day for the rest of their life. Autoimmune medications decrease inflammation, they decrease the immune response. I'm more at risk of infection, I'm more at risk of contracting things like TB and all those things in the commercials. They say, if you have, TB tests and all those things, I'm more at risk of getting sick because my immune system is decreased. Okay? So it decreases immune response, increases blood glucose. It can prevent calcium from being absorbed, so osteoporosis, lots of things that make it necessary to take it very short term. And then the ugly is that it can have a dependence. Again, think about patients that get Addison's. I'm taking steroids all the time, so I'm not going to make any more. We need to decrease the amount slowly so the body can start. It can cause edema, peptic ulcers, delayed wound healing, osteoporosis, infection. So think about the body, if it's getting too much of these things, kind of the problems that it can happen. All right, fistulas are common. Okay. So again, fistulas are more common with Crohn's because it eats all the way through. And it can be a connection between two body parts. So small and large intestine maybe, or it can go through the liver, through the kidneys. It can go from the large intestine, which is very to the outside of the body. Okay. They would need to go and repair that with surgery.
If it were to come outside the body, like wouldn't the person be like, oh my goodness, a hole, like?
When it broke all the way through, probably, yes.
Yeah, so would it, like, how would it go? Would it just start slowly deteriorating?
Yeah, and so if you think about some of these patients as well, their belly is going to be very edematous. So there's lots of pressure in that area, and it may just be an irritated area, kind of a pimple or an irritated area or something like that, and then it gets bigger and bigger, and then also they may have contents. And of course, if it's just edematous, it could be serous content, looking like an infected hair, a pimple, or something like that. Yeah. Okay. So inflammatory bowel disease, we're worried about fluid balance, we're worried about absorbing nutrients, we're worried about pain. Okay? Could affect lots of things for our patient. We're about mobility, okay? As far as not feeling well, not getting up and moving around. A bowel obstruction can happen. We said so much edema in an area that it closes off the opening from one area to another. Bowel obstructions are very serious, and we see lots of patients in the hospital for bowel obstructions. They're going to mingy too because they're going to be vomiting. You can have an obstruction, of course, in the small intestine or large intestine. This talks about if you have an obstruction in the small intestine, you're going to see symptoms much quicker than if you have it in the large. What I mean by that is, if you twisted off part of my small intestine, then things are going to get there much quicker. I'm going to be vomiting much quicker than if it has that very long pathway to get all the way to the bottom of my large intestine, because then it's going to have to build up and build up and build up and build up until I'm starting to feel symptoms. Could cause, again, that obstruction. We listen to bowel sounds. That's how we tell that there's movement in peristalsis. Decreased movement is common after surgery, right? We've had anesthesia. Their bowel sounds may be decreased. They should never be absent. And we should be listening for increasing bowel sounds as surgery hours progress. No bowel sounds go along with edematous stomach, pressure, nausea, vomiting, okay? And that is called a paralytic ileus, okay? Another term you may hear. So paralytic means paralyzed, okay? The ileus being the small intestine, we're not going to hear bowel sounds, okay? And sometimes we refer to it as that small intestine is kind of paralyzed. Yes?
How common is like necrosis with bowel obstruction? Is that pretty common?
Not really, hopefully not, because we are going to intervene very quickly. Okay. So intervening in the immediate period is clearing that obstruction. If we do that, should be any problems with blood flow to the tissues or things like that. We're going to notice that vomiting, nausea, those kind of things. We talked about anatomy. We said that an acute intestinal obstruction that happens acute, comes on quickly, most of the time is small intestine, okay? We talked about small intestine could be Crohn's, could be post-op after surgery. Because we're thinking about ulcerative colitis, it's more large intestine, right? So we think about patients, again, nausea, vomiting, stomach distended, decreased or no bowel sounds. What can happen is we think about if it's in the large intestine and it's obstructed, certainly we're not going to be vomiting from that. And if we are, it's going to be stomach contents. We don't eat anything, we're not going to be vomiting. Let me tell you what can happen. There could be so much pressure in the large intestine. Autumn's like, let's not. There could be so much pressure that back up through the pyloric sphincter, into the stomach, into the esophagus, and your patient can vomit stool. And if I hadn't seen it, I wouldn't believe it was so. But I actually had a patient that came to us who was already doing that. It was not liquid stool, it was stool. And she aspirated and died right there with her family, choking on stool. I will never forget it.
Now I won't.
So it can happen. That's why a bowel obstruction is so extremely serious. And it can happen in the small intestine or large intestine. If it happens in the large intestine, again, these are patients who are going to complain about constipation, bowel sounds decreased, distended abdomen, nausea, all those kind of things. That's why bowel sounds are so extremely important, that we listen to those and we act upon them. Okay. Bowel obstruction, mechanical blockage. Okay, mechanical being something is stuck there, stool. Paralytic ileus is the movement. Okay, the peristalsis is decreased. During surgery, we take anesthesia. It's supposed to decrease movement. Long surgeries, we are particularly concerned that that movement doesn't start to come back, and that can cause problems. So patients may have to go back to surgery if they think that there is damage to the bowel. It's no bowel sounds, they're not moving. Did they damage the bowel? Did they damage the nerves? This is talking about the malodorous, the vomiting. Higher the obstruction, small intestine, the quicker you're going to see my symptoms. Food doesn't have to go very far. Okay. Always an NG tube with a bowel obstruction. Listening to the abdomen, listening to where the bowel sounds are. Also always asking your patients, are you passing any gas? Even though they may be constipated and bowel movements since surgery, they better be passing some gas. And if you hear bowel sounds, then they should be passing gas. Okay. All right, let me get through a couple more things real quick. Bowel obstruction again, blockage. So we talked about comes on quickly, small. It doesn't take long for that to build up and me to have symptoms. We vomiting, okay? We're vomiting what's in the stomach. Stomach acid, bowel, food. Abdomen distended, hard. Large intestine, it takes a long time for that to, not a long time, but it takes longer for it to build up. Things are kind of backing up, right? If they're vomiting, it's a late sign, okay? They are already having edematous, abdomen backing up, abdominal pain, constipation, low bowel sounds. Abdomen's very distended. You can even see the loops of the intestines through the stomach. Always an NG tube, always in PO, okay? Can move through. We're not going to continue to put things in there. They have to be hydrated. They may also have to go to surgery. If there's so much damage to that part of the intestine, they may have to remove part of it. All right. Okay. Post-op care, we talked about that. All right. Okay, I'm going to leave the questions for you. I've got the answers down in the bottom. Okay. All right. Yes.
How long would you need to listen for like a minimum to determine that there's no bowel sounds?
5 minutes.
Okay.
Yes.
That's a long time.
It is a long time. Even after surgery, patients coming back should have hypoactive vowel sounds, low vowel sounds. We're going to listen in all 4 quadrants. And if we don't hear one quadrant, we're going to keep listening. Again, if they have no vowel sounds, they're more than likely going to have other symptoms with that. All right. So let me pull up ATI. Go ahead. I'm listening. Hemicolectomy. Heme is a portion. So a portion of the intestine need to be removed if there's damage to it. Usually a bowel obstruction, like we said, we see those symptoms in patients and they seek care. So a bowel obstruction itself isn't going to damage the intestines, but damage to the intestines could cause a bowel obstruction, particularly during surgery or a puncture wound or anything like that has cut off blood flow to the area or damaged the nerves in that area.
Okay.
Oh, come on. Let me think. Shoot, let me think. I've had this account for a really long time. And you know, you change your password constantly.
My biggest concern with this portion of the exam is that they all manifest pretty similarly. Like, I feel like the signs and symptoms are very parallel in some of them. So would it just be like focusing on like the diagnostics?
Well, I would say that, you know, just assessing our patient, some of the symptoms, we're going to need to look further. So, you know, if I simply asked you if they were having nausea, vomiting, abdominal pain, that would be a guess in anybody's book. But I would say, you know, what if we did a CT scan and we saw that, you know, in addition to inflammation, the patient had rebound tenderness, those kind of, it came on quickly, the patient was 16, those kind of things. So you'd have to have more pieces of that picture. Yes.
So it'll be like pretty, like descriptive in the way, it's like, oh, like this test, this
Yeah.
certain thing.
Yeah. You are 523. Let's see. All right. Let me go to be a student. Let me also say something about these. The more you use ATI, the more data it has. So if you haven't taken a lot of proctored exams, there's not a lot of data. And there's also 2 cohorts that are 523, so I'll say that. There are 2 programs. To ATI, we're going to talk about remediation and proctored exams. We were talking on break, and you have a proctored exam scheduled for us, and you have a proctored exam scheduled for OB. Okay, you'll take a proctored exam in peds, you know, so throughout the program. Did you take one in mental health? Good, take one in mental health. So you do the practice exam, you remediate from the practice exam, then you take the proctored. Based on what you get on the proctored, you remediate and take it a second time, okay? So it is a completely crazy algorithm. And so every semester I ask the same questions because it's a very kind of crazy process. So it's hard to kind of wrap your mind around if you think about it one time a semester. What happens is you'll go in and you'll take a practice exam, okay? So the practice exams, my ATI, I'll look at the practice exam. Is it in test? Okay, improve. You will have your practice exams that are open. These down at the bottom that say let's see. There's some that say targeted. Those are the quizzes that you do. Online proctored, they should say 2019. ATI updates their exams every 3 to 4 years. So 2019 is the last update. So you'll have an update and you'll take a practice exam, okay? You want to take it one time. The results from that, you will do remediation. Now, after you take it one time and you get that focused review and do remediation, you can take it as many times as you want to after that. So I usually leave them open indefinitely because even if you're in next semester or whatever, you can still go back and do these as many times as you want. Practice and whatever, if you feel the need to do that or you want to do that. So you take it, you click begin, you take it. They're usually about 60 to 70 questions. So plan about an hour to take it, okay? So you'll click begin, you'll take it. When you finish, you will go to apply. Is that correct? Oh, sorry, top, my results. Okay, go to my results. It will give you your focused review. So this is the fundamentals online practice. Don't laugh at me, I got a 26, but I only used 3 minutes to take the quiz, so I did it really quick. So you click on the practice exam you took. It'll be under practice assessments. You will get your focused review progress. It records the amount of time that you spend on here. So if your instructor tells you that you should spend so much time or whatever, that's really a recording on there to see how long it takes you to do it, okay? So what you do is you go down here to the content areas. And remember, I got a 26, so I have a lot of work to do. You click on the plus sign. If I didn't miss any in this area, I would have 100% and I wouldn't have a plus sign. So you need to remediate that area.
So what percentage do you want to remediate?
Oh, you remediate everything, everybody. Unless you get 100%, everybody remediates.
So,
let me finish it. I'm going to address your question, I promise.
No, you're fine.
I'm going to address your question. You click on the plus sign. These descriptions tell you exactly what you missed. You remediate on every one of these. Remediation is you look it up, you watch a video, focused review is going to take you to content on the ATI website to review things, to watch things, to give you information, to write your 3 bullet points of the things you missed on that, to be able to, that's your remediation. You can do 3 bullet points of the thing. So I missed delegation and supervision of assistive personnel. So what can I delegate to an UAP? I write down 3 things that I learned about delegation of a UAP, and those bullet point, and then I move on to the next one. And remember, I got a 26, so there's a lot on here. These are all very specific. So if it just said client, I wouldn't know what to look up. This is what I look up. The process for ethical dilemmas. It tells right here that I can do an ATI template for that, or I can write 3 things. It also tells you the fundamentals book, chapter 3. Okay, that's where the content's found.
And this is all due before our exam and the exam.
It is due before your proctored exam. Okay.
The same day as our exam.
That's the same day.
And I know, I'm getting there. I'm telling you, I'm going to tell you something different for us, but I'm just telling you the process, okay? The Med-Surg proctored practice exam there's one practice exam. It has everything that you'll learn through the whole program. So you don't know all that stuff. And I want you to take the practice exam. I'm going to open it. But I don't want you to freak out that you don't know all of it. You're not supposed to know any of it. You don't have to remediate from that, okay? So I do want you to take it. Have some practice that would, I think that it'll help you to prep for the exam. So spend an hour, take the exam, okay? Some of those areas, it'll tell you where you can find stuff if you didn't do well, or you say, I don't know that, or it's got about peritonitis and I need to know more about that. For OB, okay, you need to take the practice. You need to remediate. You will do much better in OB because you've had all your OB, you've had all your mental health, you've had all your peds. And unlike Med-Surg that we're learning throughout the whole program. So you'll take the proctored Med-Surg in your last class. What we're going to take is a test that I put together of things in ATI that we learned in here. And that's going to be helpful for you going into the final.
But it's not graded, but,
No, we're not going to grade it.
and this is next Friday.
Yes.
I'm confused because I didn't think that we were taking a practice for,
We're not taking a practice review, we're just taking.
because she didn't tell us that, we're just taking a proctor. So like now,
So we're
like,
we probably do the practice on our own.
Yeah, I might do it on your own then. Then she didn't say remediate, don't remediate.
okay, so then with you, so we're taking the practice before Friday and doing the remediation on the practice, but we don't do remediation on the proctor, or we do.
You don't have to do any remediation in here.
Because the information on the test or the practice that we're taking
Yeah.
is not all the information we know yet.
So I'm telling you about the general overview of
Okay, so this, we don't
ATI.
have to do this this Friday.
Right.
See, we all want that we had to take an exam, reading it by this Friday, and then we're.
No, I mean, as part of your study, I would suggest taking the practice, looking at some of those areas that we talked about in here. If you're like, oh gosh, they asked a lot about cardiac and I didn't feel like I knew that really well, that may help you to kind of point out some areas.
I have a clarification. So we are on Friday, we take our exam for this class and then our ATI exam. And then after the ATI exam on Friday, that's when we do our remediation?
No, I don't think we do remediation.
I would have you do that and we will do that, but I don't know. Somebody said, I made this test myself, so I don't know if it will give you remediation. So this class is a little bit different. It's the only class that's kind of is one I put together.
Then we're taking a practice Med-Surg exam that you are going to open up, and then we do that remediation for that practice exam and turn it in before.
For this class, you don't have to do remediation. Okay, so yeah, I know I kind of put that in there, but I'm going to just say that I would suggest for your study purposes that if you miss things, go back and look what you missed and then go read on them or something like that.
Okay, I understand now. Thank you.
Sorry, I know I made it really confusing.
It's not your fault. It was like a Canvas said something and then, yes, but you were explaining this for future references.
Yes.
Okay.
Yes.
I thought you were explaining to like
Now, I know, that's why I was like, stick with me, I'm getting there. So, we have kind of that big ATI policy, but it also may be different for your instructor. Like if she didn't tell you to remediate on the practice, but I would still take it. I'd want to know, because they're both ATI questions. I'd want to know what kind of questions on OB that ATI might ask me. Yes.
On Canvas, say remediation due by 12 before the proctor exam.
Okay, I'll change that. Yes.
Also, for the test, it says disabled by instructor. Like,
Oh,
yeah,
okay.
so she's gonna, okay, I was making.
Yeah, I will, I'll do that.
Can you send us an email?
I will, yeah. I just wanted to let you know what you needed to worry about right now, not worry.
Okay. That'd be great.
Remember, those practice exams are always open.
I just thought you had.
Well, I had originally wanted you to do remediation and all that, but we've got just too much going on.
well, that's what we were so stressed.
Thank you.
You're saying my destiny. Like last time.
I don't know if we really,
Yes, we do.
We need it.
We do it.
Thursday?
Yeah.
We do it before.
We did it on
After
class.
Yeah, after class, we do that every.
But we don't have class on Thursdays.
Yeah.
Well, then you just log in.
What I
Maybe
may
like a
do,
virtual thing with you.
we can do virtual. I'm trying to think when.
Or we make a, I don't know, I like the screen review.
Let me.
That's okay, if you're busy, it's fine.
Well,
I mean,
I
it is the last day of your finals.
Maybe I can send you guys some practice questions.
Okay, that would be awesome.
That would be helpful.
That would be awesome.
We'll do that, and then if you have questions, you might let me know.
Sometimes I just feel like I don't
A
know.
giant group FaceTime.
Let's do it.
That's a thing now.
I know, we can do it.
Yeah, I think you have up to like 30 people on it.
so if you get on there and whatever, I'm always with my phone, so I've had people before have like a group study session, and then if you have a question, you can email me.
Yay, we can do that.
Let's just call Dr. Lowe.
You can call me, I'll
I'll
hop on. I've done that too.
We add Dr. Lowe to our FaceTime schedule. Dr. Lowe, do you know these?